My name is Dr. Abib Agbatova. I am a fellowship-trained rhinologist and skull-based surgeon. I practice in Houston, Texas. My practice primarily comprises of advanced chronic sinusitis patients, as well as patients with a variety of skull-based disorders. We will be presenting a case study of a 52-year-old male with a long history of chronic rhinosinusitis. The patient had undergone prior endoscopic sinus surgery procedures involving traditional endoscopic sinus surgery in the OR setting, as well as an in-office balloon sinuplasty procedure. Despite this, and multiple rounds of oral antibiotics, systemic steroids, saline rinses, and intranasal steroid sprays, he persisted to have symptoms of headaches, postnasal drainage, as well as loss of smell. Subsequent CT examination did demonstrate near complete opacification of both the left and right frontal sinus cavities, as well as some disease involving both the anterior ethmoid and frontal recess cells. Nasal endoscopy demonstrated lateralization of bilateral middle turbinate remnants. This led to obstruction of the frontal recess. There was also noted to be bilateral mucopurulent drainage, crusting, and significant syncytial formation. Intraoperatively, the patient was noted to have significant narrowing and stenosis of the frontal recess. Again, there was noted to be mucopurulence and syncytial formation. Given his long history and propensity to scar down and close off, decision was made to perform an expanded draft 2B approach. With use of an endoscopic drill, the AP diameter of the frontal recess and frontal beak were widened. This allowed for an optimal frontal sinus and neofrontal sinus opening. After completion of the draft 2B frontal sinusotomy, traditionally I would have placed an intraoperative contour propel stent in both the left and right neofrontal ostium. However, given our increased access to in-office use for the propel device, my decision was to wait until the first or second postoperative visit, dependent on the degree of inflammation. My thought process behind in-office placement was to deploy the device in a setting of reduced inflammation, meaning less tissue edema, less crusting, less mucopurulence, and less bleeding. At the patient's second postoperative visit, the patient was noted to have minimal edema, no syncytial formation, and minimal crusting. The contour propel stents were found to be in excellent position. This was a very interesting case in light of the patient missing multiple postoperative visits secondary to both the COVID pandemic and the patient himself contracting COVID. I truly believe this was an unforeseen advantage. The 2-in-1 mechanism allowing for mechanical spacing and localized drug delivery, I believe may have prevented restenosis, syncytial formation, and the need for potential additional surgeries. At the patient's third postoperative visit, 1 month removed from the surgical date, the patient was noted to have very minimal tissue edema, no crusting, and again, no syncytial formation. There was no signs of any stenosis, and again, the contour propel stents were found to be in excellent position with minimal adjacent crusting. At the patient's fourth postoperative visit, now 3 months removed from the surgical date, the neofrontal ostium bilaterally were found to be widely patent. No evidence of mucosal edema, syncytial formation, or evidence of restenosis. The contour propel stents themselves have been degraded and/or debrided. Chronic sinusitis is a chronic inflammatory disorder. Steroids are immensely helpful. So the idea of us placing an implant that will release steroids over a period of 4 to 6 weeks, but minimizing the side effects of systemic steroids, I think is a significant advantage for patients. At this 3-month follow-up, the patient reported resolution of his sinus headaches, postnasal drainage, as well as his nasal congestion. For patients with chronic sinusitis, with true chronic rhinosinusitis, there are so many different variables in place. We all know it's a very heterogeneous disorder, and so trying to predict how one patient may heal versus another can be very, very difficult. Even in patients with nasal polyps, there's a wide spectrum. So I really like the idea of an implant, a steroid-releasing implant, as insurance in many cases. Anytime I'm doing any type of formal frontal sinus dissection, when feasible, I like placing the contour propel stent because you never know what patient is going to be prone to syncytial formation or stenosis. Some patients may have moderate disease, but may have a propensity for scar formation, whereas others may have very severe disease, but may do very well without placement. And so trying to decide who to place it in can be very, very tough. One of the advantages of now being able to place it postoperatively is that if you don't feel comfortable, or if you feel like you would like to avoid placing it in the operating room, you now have the advantage of placing it in the office setting. If you see someone who has increased edema in the frontal recess, or increased edema in the ethmoid cavity, or maybe their middle meatus is becoming a little bit more narrowing, their middle turbinate is somewhat lateralizing, now you have the option of placing a Propel stent in the office so that we can combat the edema, we can combat the inflammation, and then we can allow for mechanical spacing of the delivery device or of the Propel stent. Tissue and wound healing can be very unpredictable in this patient population. We all know that the sinus cavity that's most likely to stenose is that frontal recess and that frontal neosteum. So for me personally, any type of formal dissection involving the frontal sinus, I am most likely going to place a contour Propel stent. Whether that's in the OR or in the in-office setting will be patient dependent.
Well, Propel is a very effective way to deliver anti-inflammatory medication to the sinuses after surgery. But what it means to patients is a better chance of healing well and its outcomes, better outcomes.
Well, Propel means to me that I have an adjunct to what I wanted to perform in the first case, that is a stable result. Mostly, for me personally, that's in revision cases and in strong eosinophilic disease where you see poor results. No matter what good of a surgeon you think you are, you will have cases where you have medialized middle turbinates, and you will have cases where your frontal sinus just doesn't want to stay open. So resulting from that, like in all kinds of wound healing, you will have fibrosis and with that stenosis. To fight that means to bring steroids there, and we've tried for years and decades to bring steroids to the frontal with washes, with ointments, have people bend over and try to get any ointment up to the frontal. The bad news is it doesn't work because patients will get back up and gravity will bring it all down.
It's a very good device to actually control post-operative disease, especially in patients with severe disease. So I use it very often. I've been using it now for about 5 years. I started using it in a patient with very difficult complex frontal sinus disease, but now I can gradually see other applications for it.
Many of our patients have type 2 inflammatory disease. That's a type of inflammation that really impacts negatively the potential improvement after surgery. So anyone who has polyps, edema, thick mucus, asthma, or other risk factors for inflammatory disease that affects the airway like that is a candidate. Essentially, I think most patients who undergo sinus surgery have these problems or some group of these problems and will benefit from Propel. That's backed up by the clinical studies.
The ideal patients for Propel, for me, are the patient with frontal sinusitis, because what's available to me now is being the Propel Mini, but Contour is going to be available for me soon as well. So I use that a lot. And these are the patient usually with difficult sinus disease in the frontal sinus, so I use that Propel for them. But I could see that there's many applications for it in the ethmoids more and more now, especially in patients with severe polyps and sample-striate. I haven't done a lot. I have done, but not many. But I'm starting to use it more in these patients as well. So I think these are the two main groups: frontal sinus, difficult frontal sinus, and difficult ethmoidal polyps.
Ideal candidates for placing a Propel are clearly those patients that have a strong cellular inflammatory response.
I can't hear anyone speak.
Hello, it's a great pleasure to welcome colleagues from around the world who are joining us today from different continents and from different time zones. So it's a scientific committee of a global rhinology network, and I have with my colleague host here. On my right is Louise Melia from Bath, UK. Louise is a rhinologist and a skull-base surgeon. Then welcome Puya. Puya is joining us on a hosting panel for the first time. Puya Degani. He is from Perugia in Italy. He also is very passionate about surgical training in rhinology and runs his own foundation. And it's a great privilege to have Professor Claire Hopkins. So Claire is on my left, and she hardly needs any introduction. So Claire is from King's College London and Guy's Hospital. So she's a clinician, academic, and heavily involved in research. She was our past president of British Rhinological Society, and she was also a past president of Rhinology section of Royal Society of Medicine, and is currently General Secretary of the European Rhinology Society. So welcome, Claire, and maybe see you a long association with GRN. So essentially, GRN is a not-for-profit organization. Our mission is to foster education free for colleagues in rhinology and skull-base surgery. So we like-minded surgeons have come together and formed this organization. And it's quite a milestone event today because we're completing our 10 years since our first broadcast in 2014. So it was started as a collaboration with the Lion Foundation, Mr. John Oates, Dr. Robbie Wonsa from Basic Clinic, and Professor Wilco Grolman from Utrecht, now is at Basic Clinic. They were initial supporters, so they provided guidance to establish the organization. Then around COVID time, it was formally established as a not-for-profit organization. Since then, we have run various live surgical events. I just speak of the numbers with the most conservative estimates. Around 50,000 delegates have been benefited from our various events. Around 100 rhinology faculty have contributed to these events from around the world. So that gives a scale of it. Then today's event really spans 3 days. And there is another milestone that so far we ran a single channel and visited various operating theaters at the important stages of surgery. But there was a popular demand from everybody that they wanted to be involved in the whole surgery. So today we are going to broadcast 2 channels. So we have an option of joining one center or the other. So thank you very much for our surgeons who have very kindly agreed to operate and demonstrate surgical procedures today. So we have 2 centers. It's a Lake Como Hospital, which is attached to the University of Insubria in Italy. So Professor Paolo Castelnuovo, it doesn't need any introduction. He's a stalwart in the field. He will be guiding Associate Professor Mario Turri-Zanoni and Professor Paolo Battaglia. So these are our 3 surgeons from Italy. And we have Professor Manuel Bernal-Speckelson and Irene Perez Delgado. They're operating from Valencia in Spain. So they have chosen a very interesting cases, and there'll be lots of discussions with our hosts and interaction. So if you have any questions, please do ask them. And we'll try and pass on your questions to the faculty. There is a chat box for sending your questions, and we'll keep an eye on it. So event of this magnitude is just not possible without our supporters. And Medtronic and Carl Stolz are very heavily invested into academics, and they have always been a supporter of GRN. And we will be playing some of their informational material throughout this broadcast. So without further ado, we will now be moving on to Valencia, Spain, where Professor Manuel Bernal-Speckelson will discuss the case, and they will start the broadcast. So initially, we will be in the same studio, but then afterwards, we'll have option of going to Spain or Italy. So thank you, everybody. Thanks, Claire. Thanks, Priya. And thanks, Luis. Is there anything else you want to add at this stage? Claire?
No, just it's a great pleasure to be here with you all this morning.
Thank you. So we'll play some informational video from Medtronic, and then we'll move over to Spain.
So in aviation, the hierarchy is aviate, navigate, communicate. So first of all, you have to fly the aircraft. Only when you've got that safely done, safely achieved, you can start to navigate. And only when the navigation's taken care of do you then communicate with air traffic control. So to an extent, if you're flying, you're either navigating or you're lost. So what are the threats from being lost? Well, you might have to land at the wrong airfield or run out of fuel before you can find somewhere to land. You might infringe airspace, possibly causing a diplomatic incident. You might infringe what we call a NOTAM, which is a notice to airmen, which could be, in the UK, it could be a member of the royal family flying from A to B in a helicopter. All of these things will get you into varying degrees of trouble. And that's what we're trying to avoid. So there are several layers, if you will, of navigation. The first one, if I'm flying along, let's say I'm very familiar with my local airfield and I'm just going out for a Sunday jaunt, then I'll just be navigating visually. And I'll know all the features around that airfield, and that should be a pretty easy task. If I'm then going further afield, then I might start to use a map and stopwatch. So on my map, which has got all the airspace on it and lots of features that I can see visually, I'll draw a straight line with a ruler, and I'll work out how long that leg of navigation is and what heading I need to be on to fly that leg accurately. So we've gone from visual navigation to then map and stopwatch navigation. And after that, if I've got systems in my aircraft, I can start to use those. So as a fighter pilot in our aircraft, we had inertial navigation systems. So a bunch of accelerometers and G meters, and they work out the change from one moment to the next. And they're very resilient to maneuver, which is good if you're in a fighter aircraft. So the airplane knows where I am in one moment, and then it looks at how much acceleration I've put it under, and therefore it knows where it is subsequently. But over time, those systems drift. So over about an hour, I might lose about a mile of accuracy with that system. So every once in a while, they need updating, either by flying over a feature on the ground, or by GPS, or by radio beacons. So we had visual, we had map and stopwatch, and that was talking about my inertial system in my aircraft. And then if I'm flying along in cloud, if I'm an airline pilot, I've got inertial systems, but I'm also using radio beacons to navigate with. And they're pretty accurate. And generally airliners fly for, certainly they used to, less so these days, they used to fly from one radio beacon to another. And that's navigation in a nutshell, really. And these days, a lot of those systems are combined. So as I hinted at, the inertial navigation system will be updated by something like GPS. And GPS is very accurate, but it's not very resilient to maneuver. So combining those two, where you've got the inertial system, which puts up with the maneuvering, and you've got the GPS, which is very accurate over time, gives you a really robust system. So hopefully not too technical there, but the aim was to provide an overview of the various navigation systems.
Well, it's interesting. I sort of started training when navigation was being introduced and more accepted as routine, but we didn't use it in every case. It was considered quite fancy and high tech. And really what we've always used is key landmarks as a way to know where you are. So before you even consider operating, you'll do some form of scan, usually a CT scan. And a CT gives you better landmarks from bony anatomy, which is more reliable in surgery, because soft tissue anatomy can change. You can have swelling and shrinkage and polyps and infections and things, but the bony anatomy doesn't tend to change over time unless there's tumours, etc. So we usually have a CT scan, and before you operate, you'll go over that scan and identify those key landmarks, but also identify unusual anatomy or some changes in the anatomy that are unique to that patient. There's some key things we want to know: where are the blood vessels that supply the eye that can hang down in the nasal cavity so we don't injure those, because that can cause blindness if not addressed. We also want to know where the base of the skull is so we don't breach that if we're not intending to. We want to know where the eyes are and what the shape of that patient's orbits is, if they're a bit square or rounded, so we don't penetrate into their eye or injure any of their eye muscles. We also want to know where their optic nerve is, among other things, as well as their carotid arteries. So there's a few key things we look at as a routine, and we have a mnemonic called CLOSE, C-L-O-S-E, which looks at those key anatomic features in every patient, because they're unique in every patient. And then when you've looked at that, you've obviously examined the patient looking for other things like septal deviations or turbinates or big polyps. What we then rely on is, with the endoscope, we're relying on that anatomy. And as we proceed through the surgery, we're sort of ticking off those things in your head. Okay, I've identified that artery and I've left that alone. I've now worked out where the orbit is and I've cleaned that off. I've left that alone. I've now moved through to this particular sinus where I can now find the skull base or the optic nerve, etc. So really what we used before was anatomic landmarks and scans. Now, in dire situations where you really weren't sure, I have known of people to leave a metallic object somewhere, a CT or an X-ray, to confirm that that's where they thought they were, but that's pretty unusual. So we don't have as many fail-safes as they do in aviation. We really rely on anatomic knowledge and anatomic features as landmarks if we don't have navigation.
Well, Propel is a very effective way to deliver anti-inflammatory medication to the sinuses after surgery. But what it means to patients is a better chance of healing well and its outcomes, better outcomes.
Well, Propel means to me that I have an adjunct to what I wanted to perform in the first case, that is a stable result. Mostly, for me personally, that's in revision cases and in strong eosinophilic disease where you see poor results. No matter what good of a surgeon you think you are, you will have cases where you have medialized middle turbinates, and you will have cases where your frontal sinus just doesn't want to stay open. So resulting from that, like in all kinds of wound healing, you will have fibrosis, and with that, stenosis. To fight that means to bring steroids there, and we've tried for years and decades to bring steroids to the frontal with washes, with ointments, have people bend over and try to get any ointment up to the frontal. The bad news is it doesn't work, because patients will get back up and gravity will bring it all down.
It's a very good device to actually control post-operative disease, especially in patients with severe disease. So I use it very often. I've been using it now for about 5 years. I started using it in a patient with very difficult complex frontal sinus disease, but now I can gradually see other applications for it.
Many of our patients have type 2 inflammatory disease. That's a type of inflammation that really impacts negatively the potential improvement after surgery. So anyone who has polyps, edema, thick mucus, asthma, or other risk factors for inflammatory disease that affects the airway like that is a candidate. essentially, I think most patients who undergo sinus surgery have these problems or some group of these problems and will benefit from Propel. That's backed up by the clinical studies.
The ideal patients for Propel, for me, are the patient with frontal sinusitis, because what's available to me now is being the Propel Mini, but Contour is going to be available for me soon as well. So I use that a lot. And these are the patient usually with difficult sinus disease in the frontal sinus, so I use that Propel for them. But I could see that there's many applications for it in the ethmoids more and more now, especially in patients with severe polyps and samtostroid. I haven't done a lot. I have done, but not many. But I'm starting to use it more in these patients as well. So I think these are the two main groups: frontal sinus, difficult frontal sinus, and difficult ethmoidal polyps.
Ideal candidates for placing a Propel are clearly those patients that have a strong cellular inflammatory response.
Hello, welcome back to the studio again. So we will now move on to Valencia in Spain. Thank you. Hello, good morning, Manuel. So we have got Italy on the screen. So maybe you can check with them. Hello, Mario.
Ashok, I think you're showing very nicely that this is definitely live. This is like every morning in my theatre trying to get started.
Absolutely, yeah. They're just getting ready. I think you can see the patient is being put to sleep. Anesthetist and the theatre team is all warming up. Okay. So can we connect to Spain, please, Dinesh? If they're ready. So you can see one screen, we got Italy, and the other screen, we got Spain getting ready. Okay, so I think they're sorting out their connections, probably getting ready. So in the meantime, we can join the Italy Center, please.
¿Podemos poner el volumen de la retransmisión?
Sí.
Hello, looks like we're connected now. Hello, good morning, Manuel.
Ya está, al principio ahora le tienen que oír.
Morning, Ashok.
Hi,
Morning,
welcome, and thank you very much. Thank you to you, to Irene, and your theatre team, your technical team, for making all those great efforts to join us today. So can you hear us, Manuel? You can see the CT.
I can hear you not that well, but I can hear you, yes.
Excellent, good.
To arrange my glasses with the micro. So good morning, everybody.
Good morning.
I'd like to introduce the first patient, if that is fine with you.
This is the
Yes, please. Yeah.
Hello, morning. So the first case is a 21-year-old young lady, and she has a polyposis grade 99, I would say. The left Mackay score on both sides is around 11 out of 12. And she has hyposmia, rhinorrhea, and you will see that all sinuses are pretty much occupied with the polyps and mucus. Interestingly enough, she had asthma when she was a child, not currently. So we'll see what happens when she gets around 40 something, whether the asthma is coming back or not. Otherwise, no intolerance to aspirin derivatives so far, and well, no other important medical conditions to name. The nose is being blocked since 4 or 5 years now, and she cannot breathe. So the lady is intubated. I will now try to show you the CT scan, and we will need someone to scroll. Irene? Thank you. So you will see now the CT and the coronal section, and you see that both nasal fossae are fully occupied. Can we scroll? I cannot do it. Can you see the CT scan, Ashok?
Yes, we can see a coronal section there. But yeah, I guess you're just starting the...
Okay, let's scroll. Aquí yo no veo la actualizado. Oye, hecho, ahí tiene otra imagen que la que tenemos aquí. We only have one slice here, and while Irene has been scrolling through the CT, here on the laptop, I cannot see any change. You probably seeing the now?
Yes,
can you see that?
Yes,
great. Now we can see. Great. So this you see that both maxillary sinuses are full, that the ethmoidal sinuses are also fully occupied. You see that the lady has a Keros type 3, while the Keros is not that important from my point of view. It's more the lateral lamella, the inclination, that is more important to me. You see the maxillary sinus again, full, posterior ethmoid full, and then the sphenoid sinus almost occupied, a little bit more aeration. And you see that this is going to be a nice case. There's no septal deviation. There is no septal deviation. Currently, can we go anteriorly in order to see the notch of both ethmoidal arteries? Okay, scroll backwards, scroll backwards, scroll backwards. I'm going to show you that. This is an important landmark to me. Scroll backwards, backwards, backwards. Yes. No, this is anteriorly, backwards. Yes, to the sphenoid. Now go, 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 go. Go, 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 go. Stop. Almost. A little bit more anteriorly. We'll start to see here the notch of the both anterior ethmoidal arteries. Go a little bit anteriorly, a little bit more, a little bit more. No, I had them initially. The problem is the synchronization of the CT scan here and our laptop. So there we see the notch of the anterior ethmoidal arteries there and there. Usually I use this when I have a meningocele or meningoencephalocele of the cribriform plate, because usually the meningoencephaloceles or seals are anteriorly to the anterior ethmoidal artery. So this is a very good landmark. In any case, it's there. You see that both anterior ethmoidal cells are fully occupied. The maxillary sinuses are occupied. So it's going to be a pleasure to aerate and clean all these sinuses currently. So said this, I'll will introduce a couple of cottonoids before I start in order to have a little bit of vasoconstriction. Usually vasoconstriction should take for about 10 to 15 minutes. That's the time the adrenaline starts to work. And I think this is an important step before starting. Also during surgery, when one side is starting to bleed, you can fill the nose with cottonoids soaked in topical adrenaline and anesthesia, and then go to the other side. So give me a minute to introduce the cottonoid, and I'll be back with you.
Okay, thank you, Manuel. I think we will be joining Italy now to discuss their case. So this is an interesting case of severe nasal polyposis. So it will be available on our second channel. So we'll go back to the studio now, and those who want to follow this case, click on the second channel. So we'll be going out to the breakout rooms. Thank you. So back to Italy, please, in the studio. Can you get back to studio, please, Dinesh? Okay. So let's go back to now Italy. We'll keep the studio as it is now. Okay. Thank you. Hello, can you connect to Mario? So Mario Turri-Zanoni, he is the operating surgeon along with Professor Paolo Battaglia, and Prof. Paolo Castelnuovo is also there to help with the surgery.
Yeah. Hello to everybody. Ashok, can you hear us? Yeah?
Yes, we can hear you well. Good morning, Maria. And thank you to you and your colleagues and your team, theater team, and your technical team for making this possible.
Good morning. Okay. It's really a pleasure for us to be here with you. Greetings from our institution, our university hospital, which is the Lecom Hospital in the north part of Italy. Greetings also from our university, the University of Insubria, and from our scientific group, which is called Rhino Edu Scientific Group, that you can follow us, also our activities on the social media. So, we are almost ready to start surgery. I'm gonna show you the clinical case of today. The clinical case of today is a 69-year-old female patient. She started complaining left clear rhinorrhea over last year, and he has no previous head trauma, no history of trauma, and also she complained loss of smell, complete loss of smell since her COVID infection in 2021. The patient is a female patient. She has obesity and so very high BMI, 36.2 BMI, and also in menopause, and she has benign intracranial hypertension. So the patient underwent also some ophthalmological evaluation for intracranial hypertension, especially the fundus oculi and the fluoroangiography, and allergy to fluorescein has been during such ophthalmological evaluation. The patient also underwent CT scan and MR scan in order to go in deep in the diagnosis of a left clear rhinorrhea. And as you can see on the CT scan, we understand that there is a presence of multiple sites of skull base defects. First of all, we can examine and we can explore the olfactory groove, and there is a expansion of a dimension of olfactory groove, especially on the right side. You can see that there is a sort of meningocele in the right side olfactory groove, but also you can see that also in the left side olfactory groove there is no bone. And so there is a bilateral defect at the level of the olfactory groove. But as you know very well, usually in patients with intracranial hypertension, we have sometimes multiple sides of skull-base defect. That's why it's so important to rule out the presence of other additional features of skull-base.
Hello, Mario. I think we lost your sound a bit, so I think your headphone must have moved away.
You can hear me now?
Yes, we can hear you now. Yes, please. Yeah.
Okay. So, apart from the olfactory groove,
Hello, Mario. We lost your voice again. Can you? Hello, Mario. Hello, Mario. We can't hear you. So if you can complete the case and then case description, and then we can move with the others. Sir. No, we can't. I think.
Can you hear me now?
Yes, we can. Yeah, there is a lot of ambient noise from theater. So if you can reduce that noise, yes, we can hear you better. Thank you. Yeah.
We go very fast with the case, okay?
Yeah. Okay. Yeah. So we gathered about this defect. So, and you're mentioning about another defect. So
exactly. Not only one defect, but multiple defects. And so this is so common in patients with intracranial hypertension. And so olfactory groove, both sides, and left side lateral recess of the sphenoid in the region of the Stender canal. So also with MR scan, we can see these features. And so this is the T2 Waketon sequences, and this is the flyer sequences. And you can see that there is the signal of liquor that disappear on the flyer. And this is the fusion between flyer and T2. And you can see that here stay the signal of the liquor. And so this is a CSF leak. Similar things happens also on the level of the left sphenoid. T2 Waketon sequences, and in the fusion, the white signal, hyperintense signal on the left sphenoid stay, which means that this is CSF. Okay, once again, this signal at the level of the left sphenoid, also in the fusion. This is the endoscopic appearance, but there is no specific sign in the endoscopic appearance. Also, you can see that there is some drop of CSF, but no meningocele are evident. So, we are in presence of a bilateral olfactory cleft defect associated with a left lateral sphenoid recess CSF leak. And so we can discuss about possibility for treatment. The patient already start diuretic therapy with acetazolamide since 1 month in order to decrease the intracranial hypertension. But now we can discuss how to perform the skull-base reconstruction. Ashok, can you hear us? Yes?
Yes, very well. You can hear you very well. That's a very good quality audio. Thank you.
With Professor Castelnuovo, now we can discuss about possibility for surgical strategy in this case.
Hi, Ashok.
Hello, morning, Prof. Thank you. So welcome to GR-ESS. So it's quite an interesting case and quite a challenging case as well, I would say.
Yes,
so,
indeed. It's a challenging case.
So what is the surgical strategy, Prof?
Yes, because with the benign hypertension, intracranial hypertension, the future of this patient is very tricky. So for the skull base, for the bilateral olfactory defect, we think that the approach is with a right Haddad flap, with a resection of the superior portion of the septum. So with the right Haddad flap, we can cover both the olfactory grooves. And this is enough to resurface the anterior skull base. On the other side, for the left sphenoid defect, we can approach with a multi-layer reconstruction. That means that the first layer will be fascia lata, connective tissue. Then we perform a gasket with a fragment of septal cartilage and resurface as a third layer with a free graft of a middle turbinate mucoperiosteum. So we have a different approach for the olfactory groove and overlay reconstruction with a single flap and with a vascularized flap, and we will use Haddad. For the sphenoid sinus, to perform a multi-layer reconstruction with the fascia lata, cartilage. Will be a very interesting surgery for everybody.
Good morning, Paolo. Can I ask a couple of questions?
Yes, please.
How do you think you will approach that lateral extension of the sphenoid? Will you go transsphenoidally or transpterygoid plate, or will you be able to access the lateral wing easily?
Yes, of course. For the sphenoid, we do perform a transethmoid pterygoid approach. That it means that we make a trimming of a middle turbinate and do perform posterior ethmoidectomy and a sphenoidotomy. And we drill a little bit the pterygoid roof to approach, have more room to approach the lateral recess of sphenoid. Yes.
And for the olfactory cleft defect, is the fact that she has already lost her sense of smell one of the reasons for putting the Haddad flap up there, because you feel that she won't regain sense of smell anyway?
Well, I think that with such a bilateral defect, the olfaction will come in any case. Of course, there is she lost the olfaction after COVID, but I think that the progression of the disease makes a loss of olfaction in any case. And Haddad is very convenient flap to reconstruct the anterior skull base, and we do perform a bilateral reconstruction because you can make a resection of the superior portion of the septum in such a way we will use the right Haddad, but we will able to resurface both the side of the olfactory.
And finally, what will you do post-operatively to manage her benign intracranial hypertension? She'll stay on the acetazolamide, or?
Yes, acetazolamide we already started since 1 month, and we go ahead. The challenge of this case is the long-term follow-up, because we have to take into account to consider a magnetic resonance after 4 months, and then every 6 months for 2 years at least. And we have to consider the different sign of benign intracranial hypertension, like the tortuosity, ophthalmic nerve, and the enlargement of the liquoral space around the nerve, the flattering of the posterior part of the globe, ophthalmic globe, and then the enlargement of the ventricle, and the the stenosis of the transverse sinus. So all these medial rescue lines, we have to follow the follow-up. Another decision that we have to take in the future if the patient needs a peritoneal very critical cases in the past. We have a very good result with the ventriculoperitoneal shunt.
Interesting case. Look forward to seeing what you do.
Hello, have you heard my answer?
Thank you, Paolo.
Thank you to you. So, I think Professor Paolo Battaglia will start the surgery.
Vado là. La cassa gliela possiamo portare. Con questa camera che vi devo far vedere. La persona propria. Ok? No.
Whenever you want, ready.
Hi, everybody.
If I'm ready, I can start. If you're ready. Perfect.
Hello, Mario. Can you hear me? Hi, Paolo. Hi. Morning.
Hi.
Can you show us your theater setup?
Yeah, I'll show you the patient. We put our cotonoids to get more space. As you saw, the problem is also here we have not good spaces because we have a septal spar on the right side. And so I will remove the cotonoid so I show you better. So we are on the right side here. And you can see here the spar, the posterior spar, reducing the space, and also here in the upper space, in the upper part, we have a septal deviation. So we have to think what we have to do. Professor Castelnuovo and Dr. Turri told you yet that we will use the right ADAD flap in order to reconstruct both the olfactory area. So now I will start with the anterior incision of the ADAD. I'll try to get it as large as I can, but first of all, anterior incision, try to correct the posterior spar and the upper part of the deviation. So then we will move towards the ethmoidectomy. We will remove the middle terminate bilaterally, ethmoidectomy, and we will expose the olfactory cleft. So we will start from the olfactory cleft now. So can I have infiltration?
Paolo, there is a question for you. How do you choose which side you're going to raise the flap from? I mean, this is a reasonably central defect. So what are the factors in deciding?
Yeah. I'll start with the right side because also if I will have, and it's probably I will have a small perforation, we will have the contralateral side still intact. Instead, if I will do the left side, then it's probably that I will have the perforation on the right side, so it will be I will have a hole, a permanent hole. So we'll start from the side where there is perforation, where there is the septal spar. in order to avoid to have a persistent hole after surgery. Did you understand?
Yes, the septal spur and the deviation is one of the key factors in deciding, correct?
If I will have here a small perforation, doesn't matter, will not influence my reconstruction. Of course, a small perforation. I will have on the left side the pterygoid that I have to drill, so it's better to get on the right side where there will not the CSF leaf at the meningocele. Okay? Because we'll have to drill the pterygoid on the left side for a transethmoidal pterygoidal approach in order to get to the Stenberg canal defect.
Thank you.
Because as you
I think that's an important factor, because in drilling, there's a chance of damaging the vessel that supplies the flap.
Yeah. And also, they told you this is a very rare case of Stenberg. You see, the herniation is above V2, not between V2 and the median nerve. So this is the incidence is 1 every 1 million almost. So it's very rare. It's very rare. It's a clear and Stenberg canal defect.
Yeah, that's interesting, because usually we find the lateral sphenoid defects are lateral to the V2. So they're not really the true Stenberg canal defects. There is a debate about it. Yeah, but this looks like a very classic medial to V2, the classic Stenberg canal defect.
Yeah.
Would you agree, Claire?
Yeah, absolutely. It is very unusual. They're always described as Stenberg, but as you say, they're lateral. But this one is one of those rare ones, so it's nice to see.
So I take my time to make infiltration.
I think, and that's the key. It's very beautifully demonstrated by Paolo, that getting a good vasoconstriction, spending your time in infiltration with cotonites, a good hydrodissection, it all adds to flap integrity.
Yeah. It's better to take some minutes more, but to have then a dissection much more bloodless as we can. Okay. Then a cotonoid again, and then we'll start.
Thank you.
Okay.
Is that just adrenaline on the cotonoids?
Yeah, there is a xylometazoline, 10 ml, and there is a adrenaline 1.200,000, 10 ml. So we mix xylometazoline with adrenaline. Okay. So we start with the anterior incision of the Haddad flap. So we can use the beaver or a scalpel as you want, scalpel or beaver, okay? So here we start in the upper part, okay? I stay very anterior because then I will have to reconstruct the skull base bilaterally. So here, very anterior, the incision, then a little bit down. We use beaver, as you know, you can use, there are different kind of instrument you can use. One is the diode laser, the other one is the monopolar. We prefer to use or the diode laser or
I think the picture is a bit frozen from Italy. So that's Professor Paolo Castelnuovo, along with Mario Turri-Zanoni and Paolo Battaglia. So the main surgeon we saw was Prof. Paolo Battaglia. So they're in the Lake Como Hospital, which is a part of the University of Insubria. So it's a very interesting case, isn't it, Claire? So intracranial hypertension with multiple defects, and we're going to see surgical strategies with the flap and multi-layer reconstruction.
Yeah, they've certainly not chosen an easy case for themselves. I think both areas, the olfactory cleft, it's often quite difficult to get an underlay. It'll be interesting to see how they approach that, but certainly coming from both sides will give them a much wider access to get that underlay in and get a more watertight repair. And then access to the lateral wing of the sphenoid is always the challenge. So in both cases, technically quite difficult. And also then the peri and post-operative management of these patients is really difficult. We have a really good setup for our benign intracranial hypertension patients with our neuro-ophthalmology team, and they undergo quite aggressive weight management before surgery, previously with bariatric surgery, but now with things like Ozempic to try and bring the pressures down to help with the repair. We use acetazolamide, just like the team in Italy. And sometimes shunting, but we try to avoid that as much as possible. Patients are quite resistant to shunting, but there's an increased risk of failure. So you really need your repair to be sound.
Yeah, absolutely. I mean, it's not about the surgery and the immediate reconstruction. It's about addressing the root cause of it. That's the key. Otherwise, over a period of times, they can recur, or the defects or the leaks occur at another site. So even after the reconstruction, we need to keep working with these patients and working on the weight, controlling the BMI, and monitoring them further. That's key. I mean, do you use, I can understand in this case that the patient had a allergy to fluorescein, so they could not use the fluorescein. But what is your practice? Do you use fluorescein routinely?
So that makes it really challenging. For these cases, I think fluorescein is helpful. We will use pyrogen-free fluorescein. We'll do a patch test preoperatively to exclude allergies, and then use it intrathecally. We get our anaesthetist to help with a lumbar puncture, and then we dilute it down, put it back in. And I think that helps identify these patients with potentially multiple sites. And there are 2 obvious sites on the scan, but you can really have a look to make sure there's no other areas. But also it helps you when you're doing your repair to give you the reassurance that you have got that watertight seal, because you can see that you've adequately closed it on the table. So this is likely a case that I would use the fluorescein, not so much to identify where the leak is, because we can see that from the imaging, but to help me understand that my repair has been sufficient. Would you do the same?
Yeah, absolutely. I agree with you, because fluorescein, when possible, then it helps you to identify the other leaks. Although in this case, the 2 leaks are quite obvious. And with the new now IGS and all that, it really helps. Would you use the navigation in this case?
I would probably set it up, but I'm not sure that it's a case that really needs the navigation. Again, you can see the leaks quite clearly.
Correct. Yeah. So you just probably to confirm what we already know.
Yeah.
Exactly. So we're back on the screen. Hello, Paolo. We're back to you. We had a bit of a break in transmission in between, but I can see that you've gone forward and you raise the flap on the cartilage.
Yeah, raise the flap and go posteriorly, trying to remove this posterior spar. I expect a small perforation because of the spar you see. It's very large. But I'm not scared about this. We can use the flap anyway, no problem.
Yeah. I mean, it's quite a robust flap, isn't it? 1 or 2 perforations here or there. It doesn't make much difference.
Doesn't make any difference. Yeah.
Wonderful. And I quite liked your idea of using the beaver knife, because it's important to know that if you use a monopolar cautery here, it's kind of easy to go through the septal cartilage and cause a perforation at the very anteriorly. So using the beaver knife gives probably a better control, finding your flap and finding your planes and elevate the flap correctly. without damaging the cartilage. And anteriorly, the cartilage is also a structural support for the nose. So you have to be mindful about the structural supports to the nose. So
yeah. Anteriorly, we'll try not to remove too much cartilage here, in order because here I will have to reduce this superior deviation, but I will not too anterior in order not to have a sedge of the nose afterward. Then here I'm trying to be very careful not to make a perforation of the left side, because I don't want to have a persistent perforation also in the posterior part. If I try not to have it. So maxillary sinus probe, seeker da macellare. Lava, wash, please. Okay. So I frequently use this small probe that we use for the maxillary sinus under the crest, so that I can, you see, better detach the inferior part of the septum. Right? Wash.
That's a really nice trick, because that's one of the toughest areas to get around without tearing.
I mean, the ligaments are very strong in that area, isn't it? So going through them, you need a combination of a sharp and blunt dissection. And you can see Paolo is very beautifully showing that. He's been very careful with using the olive-ended tip, which is protecting the flap in a way. If something sharp in this area can easily cause another perforation to the flap.
Sì, probe ancora. Yeah, it takes some time, but I want to reduce the enlarging of the defect as much as I can. So here some fibers. Okay. Can detach easily in such a way. Till the floor.
So that's a classic Cottel's inferior tunnel, isn't it, Claire? And it's going on the nasal floor. So Paolo, how wide are you going to take this flap?
I'm sorry. I will try to go. Come on. Then I will go towards the nasal fossa floor, so I can enlarge much more, because I need a large flap to cover both the olfactory cleft. So I need a large, and I will go also inferiorly inside the inferior meatus. I will enlarge here my anterior incision here inferiorly. You see here. I will try to till here. You see, this is the valve, Hasner valve. So we not have to damage. So I will stop my horizontal incision under the as of the valve, the Hasner valve, in order to avoid epiphora. And then I can, in such a way, I can have a large ADAD flap. So, but now I will move on again. I have to get space. So I need here to remove the spar and go in posteriorly. Yeah. So and now I want to better understand on the left side if it's detached, and then with the hammer I will remove the crest. Modulami, per piacere. What? No? Dammi ancora la ball, il probe. I need help. Okay, yeah. Thank you. So before removing the crest, I want to be sure to have detached well the contralateral side. Okay. Now it's better. Whoosh. Okay. Here in the upper part. Okay. Now I'm quite sure not to have a contralateral perforation, so I can remove the spar. Let me see in the upper part on the right side. Okay. Okay. I almost exposed the crest. Inferior part, it's okay. Let me check better the inferior part. No, here it's still attached a little bit. Vailina? Cotton? As I can of the flap. Okay. Vailina? Then chisel, scalpello e martello.
So Claire, as you can see on the screen, it gets quite challenging, isn't it, with this septal spurs and deviation often. So it's very tactfully, he's dealing with that.
Yeah, it's time spending, but it's fundamental to move on towards the site of the defect. Go. Go. Okay. Then vial, grossa, non so big. Okay. So this is the spar. Try to see if there is some more deviation. Take here. Modulami un attimo questo. So here again, let's say if there is something remaining here. Yeah, it's a big spar. Apri. Apri.
I think what the team are already showing really clearly is how well they work together with this sort of four-handed approach and how you can swap between 2, 3 and 4 hands almost without us noticing. It's really impressive. It's nice to see that work on the screen.
Yes. Absolutely.
Okay. Yeah, it's very helpful to have a surgical partner that helps you such a well way. So let me see if we manage the posterior crest. Okay. The hole, it's not small, but will not be a problem. Okay. Okay, now we get some space. I will have to remove again some more bone here in the upper part, and of course here in the anterior portion. So.
Yeah, for those delegates who have joined a little late today, so We are operating from Lake Como Hospital in the University of Insubria in Italy. So Prof. Paolo Battaglia, who is the primary surgeon at the moment, is assisted by Mario Turri-Zanoni and guided by Prof. Paolo Castelnuovo. So it is a very interesting case with benign intracranial hypertension, multiple skull-base defects, 2 large defects, one on the right side with olfactory cleft, 1 lateral sphenoid on the left side. And the plan is to raise the right-sided nasoseptal flap, that is the Haddad flap. And that's what we're dealing with, the flap at the moment on the right-hand side. And then use a multi-layer reconstruction on the left side.
Okay. Okay. Now I want to correct also the anterior portion, so cotton. Here is the perpendicular part of ethmoid, the passage between bone and cartilage. I have the incision here. Okay. Anterior incision.
I think this is another important area, isn't it, Paolo? How high do you go at keeping the keystone area in mind?
What? Sorry.
No, this is a very important area for the structural support of the nodes.
How high I go?
The keystone.
Okay.
Yes. Yeah.
Yeah. Sorry. As much as I can here, detaching. Now I'm detaching the cartilago from the bone posteriorly. When if I will remove only the bone, not the cartilage, because I don't want that. The sedge of the nose, so I can detach till the upper part, no problem. The only thing is not to remove this 1 centimeter in the upper part of the cartilage in order to avoid the sedging. But if I have bone, now here I'm touching bone, I'm safe, and I will not have this kind of problem. Okay.
Thank you.
Here cartilage, so I will preserve. Here I will go till the upper part, you see here, and this is bone. Now, in order to correct, you see this bulging here in the upper part, I will remove the bone easily and safely. In such a way, if I remove the bone, I will not have any problems post-operatively. Do you agree?
Yes, sir. Thank you. I think so.
You're underneath the nasal bones in the bony plate, aren't you? So they're all protected.
Yeah. So here again, try not to make any hole on the other side. Again, probe, maxillary probe. I love this instrument. Sicada macellare. Okay, because I can go behind the board, the corner with the ball. The touching safely. Okay. Now I can remove this part. Or Castelnuovo also likes to drill this part, but anyway, or drill or remove vial. Oh, prada. So this is bone. See, it's quite thin. And then let's check. Also in the inferior part here we have still remaining cotton. You know, it will have been a dream to not to have a hole, but in such a case I expected. Okay, now check if we have space in the upper part or if we need to remove more bone. Okay, Vai, Spira. You see, we gain some space. Now we can check better the olfactory clefts, but I think get some more spaces in the upper part because I need to have a very clear field to better then work on the olfactory. Cotton. It's something you cannot do after. Wash, please. So here we use mainly cleaning system if we approach the cell and paracella. In such a way, you see, my assistant is with the syringe, you see? He helps me. And if you are trained, it's quite better than washing a cleaning system. I prefer.
I agree.
So,
the cleaning systems I always find a little frustrating.
Yeah, because it's not easy also to wash because you have to pull to orientate the water towards the tip of the endoscope, and at the beginning it will not be very clear, and we have to train and train. But then, when you are trained, you have a perfect, cheap cleaning system. Okay. Now we are almost satisfied about our closure. It's something still posteriorly. There is some probably. No, there was blood. Here some. Let's check posteriorly. Anyway, the pedicle of the flap is preserved. Here, with this small hole, this small, not so small, but this hole, then we'll put near the two parts of the flap, and will not reduce the guarantee of closure of our flap. So a little bit here again, superiorly. We are almost okay. Okay. A little bit more again. Ok. Aspiratore scollatore. This small part. Yeah. Ancora vial.
Marina.
Yeah. Thank you. And one a little bit more here. Vial. Ancora. Okay. Okay. Remove the blood, then position again. Okay. Now we can check the olfactory cleft. You see here the superior turbinate over there, olfactory cleft. As Mario told you before, we could not use fluorescein. We try to use in every case, but the patient had a problem during the ophthalmologic evaluation with the fluorescein, with some reaction, so we have to. We did not feel comfortable to put the fluorescein inside the brain. So let's check better the anatomy. Here is the middle turbinate, the head. Then we have the bulla over here, an accessory ostium here on the right side, and the free border of the uncinate process. Now we remove the middle turbinate as first things, and we will preserve it in the physiologic water, because we can use this middle turbinate for the mucoperiosteum as a third layer for the Stenberg canal, and the bone for a sort of gasket seal later on, or the cartilago, of course. But first things, we need to get space and better and expose the olfactory cleft. So, uno tagliente, piccolina, one cutting straight instrumentation. The small one, please, the piccolina. Any questions? So, my landmark, in order to remove the middle turbinate, please push a little bit here. Thank you. Great. Now is the, you see, axilla of the middle turbinate, then till the axilla of the superior turbinate. You see here? Can you see clearly?
Yes.
Perfect. So I will go from the axilla of the middle till the axilla of the superior, because I need to have this landmark, because if I go straight, instead of going down, you know that the skull base and a hammock shape, I will go inside the brain, inside the olfactory cleft, sorry. So you have to take in mind this important rule. So starting from the axilla, then you will have to correct your cutting inferiorly. You don't have to go straight. Thank you. Okay. Then down, down, down. Okay, a little bit of blood. It's life. Okay. Let me see the axilla there. Okay. Okay. Then, when I arrive to the axilla of the superior, I can get a small curette, and I can pull it down without breaking the common lamella. So now, you see, I can, wash please, I can pull it down. Okay. Then I want to see better. If you can reduce the blood pressure, it's okay. I ask the anesthesiologist if can help me more with the blood, so that it will be more clear. So.
Are they using Tiva, or what sort of anesthetic to give you the best?
Yeah, sure, of course, yeah. Yeah, we'll always use Tiva. Okay. So bulla, and here we'll go down. Uno tagliente.
And do you use tranexamic acid or anything else to help with bleeding?
Yeah, I can reduce bleeding. First I ask, then I can have antitendable position if it's too much. So I can put the head up a little bit of the patient. So we can try. Can you put the head a little bit up? And then, if not, use cottonoid. Stop, please. Okay. The head came up. Let's see if something changed. Yeah, quite better. I can see a little bit more. Yeah. The second surgeon helps me a lot. So, cutting instrument, uno tagliente piccola. Sorry, sometimes there is some Italian for the instruments. Wash. And warm water we can use, so I ask them to give me warm water in order to reduce the bleeding. Okay? Show me the posterior part. Okay. Now it's done. I can remove the middle turbinate. So, vial, small one, please. Okay, thank you. So, you see, this is the middle turbinate. I can see it. Okay. So, later on, we can use this detaching from the bone from one side and the other side, leaving the joining here in the inferior part of the middle turbinate for the Stenberg canal defect. So please put this piece inside, you see, physiologic water, store it, and don't send in the hashtag. Okay, now we get space. So the other thing we do, we always perform ethmoidectomy. Of course, we have to expose the olfactory cleft, so we need to know where the ethmoidal roof is. Okay, so we perform now anteroposterior ethmoidectomy. So backbiting, we need the landmarks. We need the maxillary sinus landmark, the sphenoidal landmark, and the frontal one to expose the skull base. So here, floor of the bulla, we insert our backbiting. This is not the natural ostium, it's an accessory one. You see the uncinate process moving, so we can remove the passage between the vertical and the horizontal part of the uncinate process, and then ball probe for its own way of usage. So now this is what was built for. So we can put it down and better identify. You see, Marco, can you show? Okay, you see. Now this is the natural ostium with the biscotto with the straight cutting instrument. We remove this posterior part and then basket.
We lost your picture, Paolo, a bit.
Oh, okay. Without spar, it's better. Okay, you use this instrument to remove the inferior part of the uncinate process. It's called basket. We call basket. Okay. Now I'm quite happy. Now we will remove the uncinate process. So GR-ESS, we will go in the hiatus semilunaris, then we will prepare the number 2 cutting small instrument. So between the space between the bulla and the uncinate process, we will frontalize the uncinate process in such a way. Okay, I like to leave it in such a way before cutting, straight adjacent to the papyracia. So adjacent to the papyracia, I will go up and up and up till the axilla, and then I will move a little bit medially. Small vial.
I think this is a classic swing door technique, which is the safest way to remove uncinate. Would you agree, Claire?
Yeah, nothing exceptional.
Yeah.
I do this in all my cases now. I've really moved away from doing an anti-grade uncinectomy, and this is safe and reliable in every patient.
Absolutely, because the superior part of the vertical segment of the uncinate is closest to the orbit, and there is a risk of a perforation into it. So you're safe as long as you're using this retrograde swing door technique.
Yep. GR-ESS. Now we will open the bulla. Okay. So inferomedial angle of the bulla. We will pull, you see the bulla in front of us, such a way. Number 2, big cutting instrument. There is a little bit of bleeding. Then for the frontal, perhaps we can put a cotonoid and try to wash with hot water. But now I go, in order to spare some time, vial, remove the anterior wall of the bulla. Small vial. Okay. Now we will remove the floor of the bulla.
Un colpo alla coda del medio. Un colpo alla coda del medio.
It comes from the anterior ethmoid, so take in such a way, biscotto, straight. Okay, removing the floor of the bulla. Okay. Okay, now, of course, in normal phase, with the preserving the middle turbinate, we will go towards the frontal sinus, but here it's better probably to get the sphenoid and then come anterior towards the frontal. We remove the head, the middle turbinate. So, debrider. Non funziona? Oh, no. Ok, c'è curetta. Okay, does it work now? Let's open the posterior ethmoid.
So what Paolo shows really elegantly is a really safe approach to your endoscopic sinus surgery, a retrograde appendectomy, finding fixed bony landmarks, finding the space with the curette in the bulla and then moving into posterior ethmoids, using the sphenoid as a landmark. And so this will apply to any sinus surgery, let alone CSF. Right. It's really nice.
Yeah, so we put the curette behind the uncinate process and between the uncinate process, the free border and the bulla ethmoidalis. Now we could go following here the agar nasi towards the frontal sinus, but you know, it's better to get the sphenoid, so will be easiest apri qua. To get the sphenoid here, we will follow the superior turbinate, so uno tagliente grossa o biscotto. Follow the superior turbinate over here. Okay. Push. Okay. Hot water because it's bleeding enough.
The often is a challenge in these cases, isn't it? With this benign internal hypertension with high BMI, anesthetically, they are not easy to control.
Yeah, it's not easy.
That classic hypotension, low pulse rate is always not possible. And it's quite a challenge, not for the surgeons, for the anesthetists as well, maintaining it. And,
both.
As Paolo is very diligently demonstrating, taking his own time in trying everything possible to get the hemostasis, finding the landmarks.
Cutting instruments. Yeah, and trying with uno tagliente, when it bleeds so much, I need the landmark as much as I can. So now I want to see the sphenoids. So it's one more landmark, you see, this is the posterior ethmoid. In order to get the sphenoid, I have to follow the superior turbinate. This is my main landmark nowadays. So, wash. Clean, please. Okay. Now I follow the superior turbinate and I'm almost inside the sphenoid, I think, here. Okay. This is sphenoid, you see?
Yes, yeah. Nice one.
So try to put some cotonoid inside them because it's quite bleeding. Remove this, then I will get more space. Then I will put some cotonoid to have a bleedless field. Okay. So biscotto. We call this biscuit because it has the shape of a biscuit in the morning. So we get some space now. We know that there is the sphenoid, so we can get more space.
And even in a difficult field, those fixed bony landmarks, the sphenoid gives you depth. You've got the roof of the maxillary sinus as another guide. So
Yeah.
you show how you're navigating by all of the fixed landmarks rather than relying on instrumentation. It's great.
Funghetto, mushroom. Yeah, it's very important here to get the posterior landmark because before going on, because you know the risk of damage of big vascular structure. So then, of course, I know there is my sphenoid, and anterior I can do almost what I want, but it's a very important landmark, mainly when there are scars and there is a bleeding, such in this case. So I want to enlarge my sphenoid. Okay, perfect. You see, now I'm not going down in enlarging the sphenoid because, as you know, I need to preserve my Haddad flap. So if I need to remove the basis sphenoid, I can have a rescue flap now and detach the mucosa from the bone. Okay. So I enlarge, but now I want to focus in the upper part on the ethmoid roof and the olfactory cleft. So I will enlarge only lateral and superior. Okay. Here perhaps I have some more space. Okay. Now I know where my sphenoid is, and I will come anteriorly, removing the ethmoidal cells, correct? So I know here I have my sphenoid, here are the cells of the posterior ethmoid, so I can, you know, remove without risk. Okay.
I really like the back to front approach to the ethmoids. I think it's so much safer.
Absolutely. For the junior delegates, it's important to notice that how carefully is dealing with these cells with the back to front approach, using the J-curate, breaking the cell particles and all the cell partitions, and then removing them carefully. The curate also gives a good tactile feel. You can feel the sudden transition between those thin cells to the very strong skull base.
Okay.
And again, it's a through cutting forceps, so you're not really pulling too much down. Rather, you're cutting sharp and then removing the cell partitions. So
quant'è la pressione? Okay, I have here the papyracia, so another landmark. Now I can remove this small cell over here, and then I will reduce again here my biscotto. Bush. Can reduce a little bit my turbinate, middle turbinate here, wash. Let me see. Here somewhere, I think I will try the meningo cell. That can be perhaps here, you see? Some meningeal tissue. over here. Here. Bipolar, so I can coagulate. You see the pressure? Pulsating. Okay, perhaps the meningocele went inside the pneumatization of the superior turbinate here. Tieni, bipolar, bipolare. Go. Go.
For our delegates, if you have any questions for the surgeons, please put it in the chat box so we can ask the questions to the surgeons. Thank you.
Yeah.
So feel free to put your questions in the chat box.
Vai. Vediamo se si... Vai qua. Vediamo se si riduce un po'. Vai. 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 Try to reduce the bleeding. Okay. Va. Okay, now I want to better expose the frontal to get all the landmarks, and then we will move on towards the olfactory cleft and the ethmoidal roof. So we are fighting with this blood.
It's challenging.
It's so. Sometimes it happens. Okay.
Yeah.
Push.
That's the beauty of life surgeries, isn't it? You get see the real life scenarios, and these are the challenges you'll be facing in your own practice.
Oh, so I will move to 45 degrees to get the frontal, but before I want to put a cotonoid, trying to reduce. Cotonino. Tieni.
I think I'm going to rename all my instruments in Italian. It sounds so much better. I like biscotto and cotonino.
Cotonoid. Again, other cotonoids.
Sounds much better than the patties, doesn't it, Claire?
It does.
Ok. 45 gradi. I move to 45 degrees, looking for the frontal. Okay. I'll also check if there are some area that bleeds. Okay, olfactory cleft.
It is a minor point. In a way, we take this for granted, but we have surgeons logging in from different continents and different areas, different countries. So I think it is important that whatever the cotinoids, the patties you are using, if you notice they're all radio labeled, then they have a string attached to it, and they should be all counted to as a part of the surgical practice, because not really leaving anything there. So is that a routine following the surgery, that once the surgery is done, then you count and confirm that all the patties and the packs have been removed?
This should be the agar nazi here, olfactory cleft, agar nazi. So I'll try to remove this to get in the frontal. Curette da frontale. So, middle turbinate, axilla. Here was the uncinate, middle turbinate. I've still this small cell. You see how it bleeds. It's like a hull. So, now wash. Wash. So, okay, I'm in the frontal, but believe me, because I know almost where it is, because we cannot see too much. So, funghetto da frontale. I hope that then we will expose everything, reducing also the loss of liquor and removing almost the mucosa. It will reduce this kind of bleeding. We don't have to lose our patient. Pazienza in inglese più che patient. To keep calm, okay. Okay, towards the frontal seems to be the supraorbital recess. So frontal sinus over there. Ok, funghetto da frontale. Dove?
So using a 45-degree angled scope now, right?
Oh, see, this small, let's see this small artery. Let's see if I coagulate it, if I can reduce. You see, okay. Bipolar. Okay. Hopefully, perhaps we can reduce this kind of bleeding. We use this, bipolar forceps that opens at the tip here. You see, it's closed. Let's see. Let's try to reduce in such a way. So stay in such a way. Usually these arteries does not bleed so much at this level, but here, wash. Right? Wash. Go. Go. Vai. 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 Go. Go. Vai. Ok. Vai. Vai. Go. Go. Okay. Now try to expose the ethmoidal roof and then we will be back. There is some bleeding that comes from this middle turbinate, but I want before checking for the frontal. Then 0 degree, we will move there in a larger space. So I will be back later on that posterior area. So funghetto, wash. Ok, funghetto. Let's open. A little bit more anterior.
That's the Hoseman punch, which is such a useful instrument in the frontal sinus.
Yeah, I'm inside the frontal. With the punch, I try to enlarge, but that's frontal, of course, here. Okay. Posterior wall of the frontal. There. Oh, here. Oh. Can be the anterior ethmoidal that goes inside and then some branches towards the dura where there is the meningocele. You see here?
Yes.
Okay.
Yeah.
Bipolar.
Yeah.
Yeah. Bipolar.
As you can see, there's a frontal ostium, and usually the anterior ethmoid lies one cell behind the ostium. So this probably is one of the branches coming from that.
Yeah. Usually does not lead
to
so much, but yeah. Okay.
Right. Paolo, that's excellent. Really very well done in finding that frontal. There's so much of a bleeding around.
Right? Right? Oh. Let me see if I can get there. Okay, go. Go. Okay. Go. 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 Okay. Go. Go. Okay, go. Okay, okay. Not free of blood, but it's better. Okay.
Or you can press the shape of the bipolar process.
Yeah. Castelnuovo, Professor Castelnuovo told me to show you how we manage to deal with this kind of bleeding. The problem is that you need to have this instrument. Give me, please. You see, you have to have an instrument that open the tip at the end. You cannot use the classical bipolar, the bayonet one, you see. If you have such a way bipolar, this is a bayonet, but it reproduces the shape of a normal bipolar, you see. When you go inside, tira via sti cosi. When you go inside, you have to go at the roof of the ethmoid. Take here, please, Marco. You see, if I want to go there with the bipolar, it becomes quite difficult because you see, it crosses the tips. You don't have space if you have a normal bipolar. So it's better to use these instruments with the tip, because you can put the 45-degree scope under, then with the tip of the instrument you can get at the level of the skull base. So,
yeah, it's a very handy bipolar. Call it a daisy bipolar. So,
yeah, it's very
handy.
So, wash. Now, I will move towards 0 degree. You know, here we have frontal, over here, frontal sinus, perfect. Then sphenoid here posteriorly, sphenoid posteriorly there. Then here I will have to remove this kind of mucosa medially, and all the olfactory cleft that we have to better expose and reduce the middle turbinate. Now the bleeding seems to be reduced, so we can focus our attention, you see here, on the olfactory cleft. This is I think that is reduced in the bone. It's quite eroded here in the posterior part, you see. This mucosa, it's not normal. This is the meningo cell that went inside the superior turbinate. Here, the anterior part seems to be better, but I need here to remove all the insertion of the middle turbinate. So now it seems to be better. 0 gradi.
So Paolo, there is a question from the audience. It may not be so relevant in this case because patient has already lost a sense of smell. But when you're developing this Hadad flap, how do you plan it to protect the olfaction?
Yeah, usually when we perform that flap, in order to reduce the loss of olfaction, we preserve the upper part of the Hadad. Oh, quite good. Now it's better. So what does it mean? Cotton. That we follow here, you see anterior incision, that in the upper part, our landmark is the axilla of the middle turbinate, and then we have the incision of the upper part of the Hadad, here joining the axilla of the middle turbinate towards the axilla of the superior. So we spare this upper part of the mucosa, that is where there is the olfactory tissue. And then we will go back here. So from the axilla of the superior, that is here, we join with the axilla of the middle turbinate here, and we preserve this upper portion of the mucosa. Then we can go up till we want in order to get our flap. So the secret is to not to damage this part of the mucosa. But in this case, we need to cover the olfactory cleft with the flap and to have the fenestration exactly here where there is the olfactory cleft. So later on, we will start from here. We will have our incision posteriorly and can start doing it till the axilla of the superior and down. This is our superior limit of the Haddad. Then we will drill the septum over here in order to put the Haddad flap bilaterally to cover both the olfactory cleft. It's clear? So usually this is the way to reduce the damage of the olfactory tissue. But in this case, of course, we have to sacrifice the upper part of the olfactory cleft, so the patient is anosmic yet, so we will not preserve that mucosa. Is it clear?
Right. Yeah, yes, absolutely. Thank you. That's great. And we can almost see the transition zone between the change in color. You can see the yellow olfactory cleft mucosa. It has a bit of a yellowish tinge compared to the rest of the normal nasal mucosa.
And Paolo, you haven't completed grazing your flap yet. Rather than do it at the beginning and put the flap down into the postnasal space or the maxillary sinus, you leave it in place to give you better access?
I prefer to leave it in place as much as I can, because if I put it in the rhinopharynx, you see here the bleeding, it will be a mess. So I cannot, or in the maxillary sinus, I will have to detach from the pedicle, put inside, make maxillectomy, and it will be in front of me anyway. In such a way, it will get some space. So if I can, if I don't need, I leave it in place till I can, and then I will use for reconstruction. So now I will leave it again. I will reduce the bleeding. In fact, it's due to the fact that this patient bleeding a lot. Then, so I will expose now the olfactory cleft. I will reduce the meningocele that it's almost here. You see this one till the upper part. I will remove all the upper part of the middle turbinate and expose and remove all the cell and mucosa of the ethmoid. And I will leave the flap in place. Then I will move contralaterally. I will do the same. And then at the end, I will put the flap to cover the defect. If I can take it in place, I will take it in place. Of course, if I need instead to work on the rhinopharynx, to have a four-hands technique, you can store, but remember that it will take some space anyway.
Thank you. That's excellent tip, Paolo. I think it's probably, may I take this opportunity to talk about Paolo. So Paolo is Professor Paolo Battaglia. He has been personally mentored by Prof. Paolo Castelnuovo. He worked in a hospital in Varese for 20 years with Prof. Castelnuovo. So then he has recently been transferred to Lake Como Hospital, where he's a chairman of the department. Paolo is also now the advisory board member for European Rhinological Society.
Yeah. Bipolare. If you want, Professor Castelnuovo can have the microphone. If you want to ask something, we have the lucky to have him with us. So.
Yeah, thank you, Prof. I mean, Prof. Paolo Castelnuovo is always there as an operating surgeon right from our first GRN live surgical webcast. He has almost performed very interesting cases, various skull base reconstructions, and large tumor excisions.
Biscotto. Biscotto. Let's go around the meningocele here. This is bone. Okay. Let's see the meningocele. Cottle. See here, this is the herniating part. You see, it went inside the middle turbinate, the superior turbinate. That's clean. I detach here. Ok. Aspira. Aspira qua sopra. Yeah, this is herniating brain, meningeal tissue. You see here? I'm going very slowly in order to better show you the herniation. Okay. Vai, go, thank you. You see, Marco, it's helping me. Pushing, okay, good. Okay. Now remove the bone. Biscotto. Wash.
I think, Claire, it is interesting to note that Paolo didn't really rush to find the defect. He did all the other steps first, sorted all the sinuses, found his landmarks, controlled the bleeding, and then, without having to look for it, you almost land into the defect, isn't it? It seems so easy once the other things have been
and if you try and find it right from the outset, it's actually very difficult. You're working in a very narrow cleft, but as you can see, it's sort of herniating into the root of the superior middle turbinate. So by clearing and making all the space and resecting, it takes you to the meningeal. You've got beautiful landmarks around with the skull base, the lamina, the sphenoid.
Yeah, absolutely.
Biscotto, you see, there is not only one herniation, but two seams in the same side. You see here anteriorly, see, one?
Yes, yeah.
And then here posteriorly. So that's why it's better to expose all the olfactory cleft when you try to repair this kind of CSF, because sometimes you cannot see perfectly in them and then you can find multiple defects on the same sides, and erosion, a reduction of the strength of all the olfactory cleft, such in this case. So try to reduce and remove all the major turbinate, exposing all the olfactory cleft. So here, try to take some space. Okay. Now it's much better. You see the bleed decreased, and now we can work much better. So, apri. Dai, uno di là, uno di qua, così se è chiuso possiamo usare l'altro per piacere. Tanto adesso il debrider, grazie mille. Ok, bipolar.
So this is precisely the scenario that, Claire, you're alluding to when we discussed this case beforehand, that the fluorescein that you use to find out if there are any other defects, because sometimes those become apparent with the fluorescein or more exploration. So Paolo didn't have that benefit of fluorescein, but he still mitigated that by having a wide exposure and keeping a mind open to the other possibilities. Yeah, if you keep that in mind, you notice those defects.
Yeah, in such a way we don't have fluorescein, so it's also much more important to see where are all, because are less clear than with the fluorescein. Totally agree. Takes time. Okay, it's not a problem. I will take my time, having a coagulation, exposing all the olfactory cleft. Here, I don't know if the meningocele involved also here medially. So now I want to remove this small and I want to check if there is brain inside or.
But the tissue in a meningoencephalocele is usually non-functioning. Would you agree?
Yeah, totally agree. So we can coagulate without problem.
Yeah.
We cannot do if there is for example, if you make a craniectomy, an extended craniectomy, and if you have as a complication a brain and herniation, I suggest you not to cut or coagulate because it's still functional. But here, if it grows slowly, it will be not functional tissue. Okay. So now I can coagulate here. Go. 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 Okay. I move to 45 degrees. Try to remove all the mucosa and to better understand the site of the defect. So. This is not the case of a small meningocele. Okay, debrider, where it's very isolated in one small piece. Here there is all the cleft that it's almost reduced in depth. So. Oh, now we can use for the first time the shaver. Okay, getting more space here. I tried before not to use too much the shaver. When it bleeds too much, usually it increases. Okay. Now I can remove all the mucosa. Okay, now I can go selectively on the mucosa. I know where is the meningocele, I know where are the cells, and removing selectively the mucosa. Perfect. Much better. Frontal sinus now, I can see it better. I know almost here there will be, you see, anterior ethmoidal artery over here. And here pulsating all the olfactory cleft. Still, I want to better understand here if it's only bone or if there is a meningocele here in the middle part. So, metti a fuoco.
And you're removing the mucosa so that your Haddad flap adheres better?
Yeah. Okay, now here, let me see. Still some bone. Curette. Push. Okay. Good. Curette. You see, there is still some bone here. Okay. Okay. There was bone. Now anterior ethmoidal artery. Remove the bone and can coagulate this soft tissue. Okay, bipolar again now. So I put my bipolar inside, I go in, I see it from below. Now I can coagulate here. Okay. Here we have the anterior ethmoidal artery. Go. Okay. Pulisci la punta, clear the tip, please.
Well, that looks like the area of the anterethmoid arteries. It's at the frontal ostium, and they just sail behind it.
Posterior ethmoidal artery, probably a middle one here, posterior, middle, and anterior.
Anterior, yeah.
Anterior ethmoidal artery, probably a middle one here, and the posterior one here.
I think that middle ethmoid's much more common than the textbook suggests.
Yeah, 30%. So anterior. Middle.
Yeah, did Mario say 30%?
Right, yeah.
Yeah, I would agree with that, yeah.
1 or 2, this one, I don't know, a small, no, a small nerve, probably. So middle and posterior, great, okay. Sorry.
Hey, Paolo, there are messages for you from Dr. Muhammad from Amman and Dr. Lestari from Jakarta, Indonesia, and many others. They are saying thank you for such a wonderful demonstration so far. They're really enjoying the surgery.
Oh, thank you. Me too now.
Okay. Yes, as the bleeding is under good control.
Okay, go. Wash, please. Clear. Wash me the teeth. Okay. Now, okay. Isolating all the olfactory cleft. Right. Good. Here. So here, it's almost good. Go. Okay. Go. Go.
Ashok, can you hear me?
Yes, I can. Yeah.
Yeah. There is some
Mario?
comment from the side of Professor Castelnuovo.
Yes, sure. Yeah.
When you use bipolar close to the skull and on the dura, the power has to be no more than 30 watt. I think it's important. We have to reduce the power of the bipolar.
Okay. Thank you, Prof. That's
and is mandatory the accuracy that Professor Battaglia has now to expose the defect of the skull base, because the exposure of the defect and the clearance of all the tissue around is mandatory for reconstruction.
Thank you, Paolo.
Okay. Now you see that I almost exposed, without entering inside the dura, the olfactory cleft, reducing the meningocele. So, see here. Here, it's olfactory cleft. The lamina lateralis, yes. Now it's almost exposed. I will reduce this tissue a little bit in the anterior part, but what I want to do now is to remove the mucosa of these cells, because then I will have to put the ADAD on the ethmoidal roof, and I don't want to put the ADAD on the mucosa. So una 4 piccola vailina. So I try to remove the mucosa of all the ethmoidal roof. So I have to prepare my field. So the key points in skull base reconstruction are exposing the defect. So you see that we took a lot of time to perform, to get our landmarks against the bleeding and to expose the defect. Now, the second key point is undermining the borders, the margins. So you saw that I want to see perfectly where the defect is. So now I can check. This is the border. This is the border. Here the bone, it's not so hard, but here it's the border. I can expose a little bit better also here. Then, third thing, I have to prepare the bed for receiving the flap or the free graft. So always in my mind I have four different things to do. So get the landmarks, expose the defect, undermining the margins, then remove the mucosa and to prepare the bed for the flap. Okay? You have to say 1, 2, 3, done, okay, ready to put the flap on. So now I have to prepare the bed. Meticulously. All these 3 steps will influence the success of your reconstruction. You can expose very well, but if you leave the mucosa, you reduce the success of your reconstruction. So remove the mucosa here at the level of the anterior ethmoid and papyracea. Here you see anterior ethmoidal artery. It's quite risky, but I have to remove the mucosa and to remove this spar. So it takes time, no problem. Yes, drill cut, please. So okay. Okay, mucosa away on the ethmoidal roof. This is what Professor Castelnuovo taught us in all his lectures. Do you want to say something more, Prof, please, from your experience? Weil?
The integration of the different tissue is very important. So to prepare the bed, accepting the Haddad, it's important because the mucoperiosteum of the Haddad has to lay on the bone of the skull base. So periosteum on the bone means a very good adhesion.
Thank you, Prof.
Okay. Mucosa, there is still mucosa posteriorly, probably. There, again, Weil. Okay, good. You see, removing the mucosa, you can better appreciate the bony borders. You see, now I have removed the mucosa here anteriorly. I will leave the mucosa on the frontal sinus because I will not cover this area. Then posteriorly here remove the mucosa. There is still some mucosa here in the posterior ethmoid and here, but I have to remove and drill this bone. So remove the mucosa still here. Sempre una 4.
Paolo, I remember a few years back in one of our live transmission, Prof was operating on a different clinical situation. It was an inverted papilloma. And he demonstrated how to be careful in removing every bits and piece of the mucosa from the ethmoid, the maxillary sinus. That dissection, I mean, it's still in memory. And I mean, that case is still available. You're going to watch on our GRN channel. But that was an absolute masterly, you know. And I can see now that you are approaching it very similarly in a different scenario, preparing the bed for the flap.
Yeah, the concept still repeats also in removing papillomas. You have to be careful. The most important things that Castelnuovo taught us is to be meticulous and to lose time to do things as much better as we can. It's not a question of who is the fastest in this room. It's you have to take time, to take landmark, to check for the borders here. Here we have a small fragment here of the bone. Okay, take time and we'll drill it. We need to take our time and to follow our rules to increase the success. So now I will drill and try to smooth. Another important thing is to smooth the field that will accept the flap. So we have to smooth the bony spars. So we can use this one. It's a curved, you saw, 35,000 drill endonasal with the curve shaped so that we can better drill the skull base. So let's check if it works. So, ragazzi, 35.000 deve andare. 35. So. We are going towards 35. Yeah, now it's good. 35,000. Okay, bipolar. Bipolar. Good. So go.
So Claire, looking at this nice field and lovely exposure now, it's so easy to forget the starting point.
Yeah.
Isn't it? How crowded the space was, how bleeding, and how difficult it was.
But it just shows how, as Paolo said, taking time and doing it in a very safe, stepwise approach gets you to this point, even from a very difficult start.
Absolutely.
Okay. Okay. Good. Now, here, Castelnuovo, Prof, would you do something more in your experience here in exposing the defect? No.
I think now it's very good.
Now it's good. So, I want to be more good than you think, so also this one. But then it's done. Okay, ready to put the flap on. We will have the fenestration, I think, after we expose the olfactory cleft on the other side. If not, it will beat more. So I expose all the olfactory cleft. I want to check the margins. I removed all the mucosa. Go. Let's see all together. Let's check the mucosa of the olfactory cleft from the posterior part to the anterior. So go. So here, okay. Go. Here, almost okay. The borders, I can see. Wash. Here, we are at the limit. Perfect. Go. Let's see if there is some more herniation here. Go. Okay. Go. Perfect. Now here, go. We are okay. Here. Okay. Try not to up too much, but okay. You can see the border, yeah, go. Here the borders, okay. Here, okay. Okay. Here anteriorly, go. Okay. Go. Okay. 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 Go. Okay, perfect. So Now I'm happy, ready to get the flap. I will go to the contralateral side. I don't know, do you have other surgery? Do you want to skip the part of the ethmoidectomy and then we will be back as you want?
No, thank you, Paolo. I think maybe we'll take a very short break for a few minutes and then we will join back because we're running 2 channels and we would love to stay with you as long as we can. So and those who are interested in nasal polyps, sorry?
So you will not see the part that bleeds.
We're seeing the worst, isn't it? So I'm sure we'll deal with it. So we'll have a very short break. We'll play some informational videos. Just to remind our viewers that Prof. Manuel Bernal-Spiekelsen and Irina Perez, they are operating in Valencia in Spain. They are available on the 2nd channel. They also have a very interesting case with the severe nasal polyposis. And I'm watching through my corner of the eye on the other screen, and that seems to be equally challenging with the bleeding and everything. So you have an option of watching that space. And don't worry if you missed that case so far. The recordings will be available for you to view later on for both of these clinical cases. So thank you, and we'll be back again in a few minutes.
Okay, see you later. Thank you.
See you.
La faccia che era biscotto. Belina?
So from the aviation perspective, just before I left the front line, we started to get pre-flight planning systems that would allow us to overlay our route onto a topographical map of terrain around us. So what that meant as a strike pilot, I could get a visual perspective during planning of what I'd expect to see in the flight. And these were very critical phases of flight where you needed to be pinpoint accurate to get weapons in the right place. And having this memory of what things should look like in the heat of the moment was a massive help and meant that you were much more likely to have mission success as a result. So getting back to, in the air, as I said, it was all about managing workload before. And if I have a navigation system, then I can delegate a lot of that aviate, navigate, communicate task to the navigation system. So much like having a GPS in a car, in aircraft these days, you've got a similar display, which is your aircraft in the middle and the route ahead of you. And depending if it's an airliner or a fighter, obviously the displays will be tailored accordingly. But it really reduces my workload. It means I can spend more time looking out of the window, not just at the pretty pictures, but looking for other aircraft that might be trying to do me harm, or looking for weather that might affect my ability to carry out the mission. One thing we need to guard against is complacency. So the people who assumed that the navigation system was correct all the time, very occasionally were caught out. For example, when I was at low level in my Harrier, I updated my navigation system on the wrong lake and put myself 3 miles out. So that was a bit of a newbie mistake to make, but those are very salient lessons that stay with you throughout your flying career. These days, of course, there's a lot more resilience in the navigation solution, and this is where the GPS input comes in to bring things back on track. So particularly in things like airline flying, there's still a bit of complacency to guard against because everything runs on rails for 99% of the time. It's just a 1% of the time when it doesn't that you need to be very focused and sharp all of a sudden in amongst this potential 8-hour flight where you suffer naturally from low arousal. I guess that's very different in surgery. So navigation very much helps your mental reserve. Need to guard against complacency, but by and large, we wouldn't be without it these days, with very few exceptions.
I agree. It does reduce your mental workload and also your physiological stress quite a bit. And again, there's a lot of research behind that. When you've got navigation, you know you're going to do a better operation. You know you can constantly recheck if you come across something that's you're not quite sure, you're a bit confused, you just want to double check as you're moving through. And you know if you've got navigation, that workload is reduced. And it has been shown, particularly in skull-based surgery, it will reduce the time of the surgery and you'll do a more complete operation. So knowing that also reduces your mental workload because you're going to get a better outcome with less complications, particularly in skull base. The other thing I was listening to with Jim is the complacency, and I agree. The thing about surgeries, we haven't had it for as long as you have in aviation. And so we haven't quite become as dependent upon it yet, but I can certainly see that becoming a problem. For us, because it can be an additional expense, we often have to justify the use of navigation. And so by doing that, you've already thought through why you need it and how you're going to use it and whether you can do without it or not. But complacency, you can certainly see becoming a problem. But even though you can put a probe in and see where you are, you still need to be able to interpret what that is. And so for us, even though you're putting a probe in and seeing where you need to know what that is and what you need to avoid and what's next and where certain structures are. So just using navigation on its own is certainly not enough. You need that anatomic knowledge. The other thing about navigation is you can actually use it then to confer with someone if you are not 100% sure. You can use it as like a conference tool. And the good thing about it these days is we've also got sort of virtual options to share things with somebody else. And so in a way, you can always return back to your anatomy as your anatomic knowledge as a backup, but you can also use navigation to confer with somebody else. It's always been thought that the navigation could prove a distraction. And potentially when you're first starting, like anything, that could be the case. But as you become more familiar with it and more comfortable with it, it's actually the complete opposite. It's an adjunct, but not a distraction. And it also just improves the workflow. You routinely check it. It's often attached to the tool that you're using, so you're not having to change tools. And you're just checking a screen regularly as you go through. And as you find that as you become more and more comfortable with that, it actually makes the whole procedure more efficient, I find. Definitely navigation is needed in certain circumstances. As I was saying before, if it's a revision case or if it's a tumour that has destroyed key anatomic landmarks, having navigation is vital. It's a great teaching tool, but again, you have to justify its use. But I think also if you've got some unusual anatomy or when you're going to be changing that anatomy and it puts other structures at risk, in ENT, the main, or in skull base and rhinology, the main structures we're worried about is the brain and the eye and the carotid artery. And if those structures are unusual, have been changed, or where the pathology puts them at risk, that's when you would certainly use it. When you don't need to use it, if you've got a case where the anatomy is relatively routine, you're not doing a big operation, and well, there's nothing really abnormal or concerning with the surgery, then you could say it's potentially not justified. When I worked in the US, they used it for every single case, and for numerous reasons, one of which was teaching, one of which was medico-legal. In Australia, it's not such the case. In Australia, we tend to need to justify when we use it and why. So that's when I use navigation.
But echo Raywin's comments there. There are times when navigation isn't required. So, for example, if I'm a private pilot just exercising my aeroplane on a Sunday morning and I'm just flying around the local area, then I probably won't use it. But that said, even these days, or particularly these days, I can put my mobile phone on the aircraft instrument panel, and for $100 a year, I can get a navigation app on there. And for another maybe $300, I can get a little black box I can put in my airplane that can pick up other aircraft that are squawking, that have a transponder code around me. So that is a massive enhancement to flight safety, even if I'm just doing my Sunday pilot lap of the block. And it means I'm much less likely to hit other aircraft or scare myself by getting closer to them. So even for the low tariff trips, I think navigation is still very useful. And for the high tariff trips, that's when the workload leveling really becomes a game changer. And it means I can spend more time as an airline pilot monitoring the systems or thinking about the destination, as a fighter pilot monitoring the tactical system and making sure that no one's getting the upper hand on me. And in terms of how it affects my assessment of a situation, it just gives me that extra capacity to be able to carry out those more challenging tasks.
The Propel family of products are the first and only steroid-releasing implants clinically proven to improve outcomes of sinus surgery. The Propel Contour Delivery System has a low-profile, malleable tip which allows for accurate placement in smaller sinus ostia and is adjustable to facilitate delivery in varied patient anatomy. Propel Contour is placed in a surgically opened frontal sinus ostium. Its adaptable hourglass shape is designed to conform to the frontal sinus ostium and prop open the sinus while delivering mometasone furoate directly to the sinus lining as the implant dissolves. The Propel family of products allow patients undergoing sinus surgery to receive the only steroid-releasing implants backed by clinical evidence to improve sinus surgery outcomes.
Hello, welcome back again. Hi, Claire.
Hi there.
Hi.
All good.
Hi. How is it? Do you enjoy the surgery so far?
It's been great. It's really interesting to see how Paolo's approached quite a difficult field initially, and to get to a point where, as you saw it before we switched over, the field was perfect, the exposure was excellent. He's all set up to repair the right-hand side. So, I think it's much more useful for us as viewers to see someone go through those challenges than to find a really easy case where that doesn't really occur. So it's been really helpful.
Yeah,
I've taken 2 minutes. I'm going to use the little maxillary probe to raise my flap around the crest. I thought that was great.
Yeah, exactly.
And it just shows the importance of patience. I think they've both been really helpful.
Yeah, and I think the end product or the mid product, so to say, what we saw, that was fantastic, wasn't it? So all very lovely wide exposure, all the mucosa was denuded. Then carefully, all the defect was the bipolar, the defect, and ready for the flap.
Yeah, it's looking good.
Okay, good. Okay, I think they had finished the first case in Spain. Prof. Manuel and Irene, they finished their case. I think I hear it was an equally challenging case, but it went well. A lot of bleeding, is that right? Verena?
Yeah, and I think though what it shows, a shock, again, is a real life situation. You have what you think might seem like a simple case, just a polyp case, but actually it just shows how challenging these cases can be when there's so much inflammation and you need to try and control the field.
Yeah, excellent. So how was your impression, Priya?
So our patient was quite interesting. Initially, Bernard had the same difficulties regarding the blood and the visual field. Then he tried to manage it. I think that everything goes back to the inflammation and type of the polyposis of these patients, and the management. As the delegate asked, what is the treatment, the post-operative treatment, and maintenance of these patients? So it was important, I think, how to combine surgical and medication in these patients.
Yeah, true. I mean, is the preparation. So I think let's join Lake Como Hospital in Italy now. So they have finished the preparation for the flap on the right side for reconstruction. Now they are on the left side.
Yeah.
So Paolo, can we join you now?
Can you hear me?
Yes, we can.
Oh, okay. So now we have a bilateral olfactory cleft meningoencephalocele. So I'm doing the same thing on this side. Here I enlarge the maxillectomy because later on Professor Turri will show you the transethmoidal pterygoidal approach for the Stenberg canal CSF. I open the sphenoid here, but I don't want to go more over here. Now I want to expose again the defect on the olfactory cleft. And after we expose also this defect, we will move towards the sphenoid, and in the end we will reconstruct. So first we expose the defect so that if we need something more, if we can see something different, some more difficult, high pressure on the sphenoid, we can change strategy perhaps in some way. So I prefer expose the defect of all the defects, and then to take a moment and to say, okay, this is what we planned, this is what we have to do, nothing was different from our plans. So before I expose all the defects, and then we will go to do the plasty. Now we will have to expose all the ethmoidal roof also in this side. You see, luckily the bleed now is controlled. You see, much better now than before. Here the posterior ethmoid still exposed. Probably here we can have somewhere the posterior ethmoidal artery, somewhere there. The maxillary sinus was opened. Now I want to expose the frontal sinus and the olfactory cleft. I think will take not so many time. So.
So Paolo, just to orientate our junior delegates, I think the defect was predominantly on the right side, but it was a kind of central defect as well. So you're approaching bilaterally, correct?
Yeah, of course. Yeah, it was it was not a classical meningocele, a small one in the middle third or posterior third. This was a multiple homolateral defect at the level of the olfactory cleft due to its condition of intracranial hypertension. So we have to consider not only, as always we say, the site of the defect, but also the condition of the patient, the pressure, so the intracranial pressure. So all these things conditionate our choosing what to choose to reconstruct. In this case, if we have usually a small meningocele correct of the olfactory cleft, we perform an overlay technique of reparation. But for single defects, in this way, the site, it's okay for overlay technique, but the condition of the patient, the multiple site intracranial hypertension, change our way of choose the plasty of the defect. Okay, so it's not a question, it's only a question of site and sites, but it's a question of condition of the patient also and the pressure, intracranial pressure. Okay, now.
There is another question from the delegates, Paolo, that may not be applicable to this situation, but do you usually do the reverse flap on the other side when you raise Haddad flap?
No, we will do the Haddad. We will have the fenestration here on the superior part, and we will use for both olfactory cleft. We will make a window here. And so the Haddad we will be bilaterally, will cover bilaterally. And for the stemmer, we think to do a sort of gasket seal so that we spare the mucoperiosteum of the left side, reducing the morbidity of the approach. We don't use two Haddad flap. We use one side Haddad flap. So we preserve the septum.
Correct. But in other situations, that's fine. Thank you. I mean, I get it that you do the single-sided Haddad flap with this, but in other situations, do you do reverse flap when from the other side when you raise Haddad flap? That was the question.
Yeah, we don't frequently use the reverse flap. We put a elastic sheet usually at the level of the side where we do the superiosteal dissection for the harvesting the Haddad.
Okay. Right. So you tend to keep it the other side intact.
Yeah, we don't used to really, not so frequent. We use the reverse flap.
Okay.
So now I will open the frontal, I hope. Allora, so then we will move towards the olfactory cleft. The cats, it's quite hyperostotic. So let's see if we have some landmark. We have to open here. Okay, so correct. So supraorbital recess here. We need to, remove this bone. Okay.
And as for the other side, you show really nicely how if you know your anatomy, you've got clear bony landmarks, you don't need navigation, even with sort of hyperostosis and a difficult field. So it's really nice demonstration.
Yeah, first anatomy, and then, of course, can be useful if there are scars, the anatomy, it's all, you know, not well, not easy. It's a confirmation, the navigation cannot, of course, overcome to the loss of knowledge. This is very important, yeah, also for the youngest generation. I am young. So the frontal here, so it's difficult. So what I think now, it's not an easy frontal. So let's try without navigation to find the solution. So let's try to do all together the approach to the frontal. So now what I have is the maxillary sinus here, okay? And this is one landmark. Then the sphenoid, it's open. Luckily, I have all the roof of ethmoid. I know this is ethmoidal roof. I know this is probably, I think, the posterior ethmoidal artery over here. Then this is here it starts the supraorbital recess. Here anteriorly, this is the axilla of the middle turbinate. I exposed the nasolacrimal duct push, you see? This is the sac. So I have the ethmoidal roof, the sac, and the sac brings me towards the frontal. So I know this is ethmoidal roof. I think the frontal will be almost here, okay? Now let's try with the seeker. You see, now sac, follow the sac, axilla, the axilla is over there, and the ethmoidal roof. This is the area where I'm trying to look for the frontal. I use a seeker before. Of course, I saw also the images, but now anatomically speaking. So let's try here. Does not go. Here there is a cell. Okay. This is the way, probably. So, curette. More medial, as usual. Okay. I need the curette, the mushroom. Did you follow my way to think?
Yeah, no, that was very nice. I think you said on the other side, sometimes you just know where it is with experience, but that's quite difficult then to train. So your steps with the nasolacrimal duct and following that line up was really clear. That was good.
Okay. I think we should drill there because it's hyperostotic bone. So I want to drill here this hyperostotic bone. So drill, curve drill, 300,000 drill. Okay. Wash. I remove this hyperostotic bone anteriorly to get better access posteriorly. The level of the axilla, okay.
So this sort of axillectomy approach is what Richard Harvey and the Australians would describe as Caroline's window, to really sort of help take away that frontal beak, isn't it?
Yeah. It gives more space here. If not, I will be, you know, as cover like this. Also, I'm using 45 degree, but if you don't remove this upper part, you will reduce the window to your access, and you will be in a hole. In such a way, you have more space. Suck.
And having drilled some of the bone there, will you cover that with a free mucosal graft at the end?
Do you mean the axillary flap mucosa?
Yeah.
Yeah, you can. Oh yeah, we use sometimes. Here we can probably use. We could use this mucosa to cover this area if we want. Yeah, of course, it's a good idea. Yeah, yeah. You see, it's hyperostotic, really hyperostotic. Drill. Okay, whoosh. Better to stay anterior here instead of posterior in order to avoid to enlarge the defect in this case.
And that's the same angled diamond burr that you were using to smooth down the partitions on the other side.
Yeah, exactly. It's you know, I think more than 70, 75, 70 degree. Yeah, you see the angle.
Yeah, very nice.
Let's check. Okay, so I have to drill a little much more. Okay, I don't want to perform a draft. I want to enlarge and to check for the frontal sinus. So. Okay. Correct. Correct. Okay. I'm inside, but it's very hard.
Yeah, this frontal is very challenging, isn't it?
Yeah.
With a lot of mucosal.
So we do need to drill a little more. You see how narrow? Let's check with the MR. Let us show you if I can. Put a coronal view with the TC. Mushroom, let's see if the mushrooms goes on. Vai sul frontale, let's go to the frontale. Funghetto curvo. Vai. That's too narrow. Oh, you see? Not insert the mushroom, so still too narrow. Vieni avanti, fammi vedere l'accesso.
Yes, there is an update from Valencia, Spain, Professor Manuel Bernal and Irene. They'll be starting their second surgery pretty soon. So the patient is just being put to sleep. So in a short while, they'll be ready to start with the case discussion and the case. So we'll keep you updated. So those who are interested in seeing Samtus triad, nasal polyps, it is available on the second channel. So Claire, interesting you mentioned about the Caroline's window. That's quite a useful technique, isn't it? And especially in the situations where your standard approaches to find the frontal are quite difficult. And then it does help what Paolo has shown today.
Yeah, I think when you've got that very narrow AP diameter, you know, I was always taught that as soon as you drill, you need to do a draft 3 because a 2A, 2B isn't going to be enough to stop stenosis. But I think Richard Harvey's really nicely shown that if you really take that anterior beak away, you can get very good outcomes with a unilateral approach. So I think it gives us another tool in a difficult frontal sinus.
Absolutely. I think on the last line is he demonstrated the technique very beautifully. The Caroline's windows, all the detailed steps are there in that video. It's available on our GR website. And Richard is again performing on Wednesday. So that will be there Thursday. So with the GMT, we start on Wednesday. Danny Prevedello and Prof. Ricara from Ohio, Columbus, Ohio. They will be starting with a big skull base case. I understand they have a large craniopharyngioma lined up. They're expecting it around 7-8 hours surgery. So it's going to be a good anatomical and surgical tour in a way. So the minute they're finishing, we're joining Richard Harvey in Sydney. So that will be still Wednesday for us, but Thursday for Richard. So in the morning, so he'll be demonstrating around 3 cases. And it is a possibility that we get to see this Caroline's window technique.
Funghetto.
And I'd just like to take this moment to congratulate you, Ashok. This is a fantastic thing that you've put together. And I think it's so valuable to see things live, to see people deal with challenges rather than a very carefully edited video in the perfect setting. You know, these are things that we all face, and it's really valuable to see the different tricks to deal with it. So congratulations.
Yeah, absolutely. Thank you.
So now we got it. I hope you see. This was why it was quite difficult, you know. It's why the anterior-posterior diameter, you see, it was quite not so huge. So I need to drill the beak, and now I got my target, the frontal. But you see here, the anterior-posterior diameter was very narrow. In this case, we have to expose the sac. It's our landmark here, and then the ethmoidal roof, and now we got it there. We can enlarge a little bit medially, and then we will expose the olfactory cleft again.
Thank you. Yeah. I think Prof. Manuel has started his case now. He's showing the case discussion. So may I request Puya and Luis to join Prof. And he's just going through his case. Thank you.
Thank you. Okay. Ok, 0 gradi.
I think another thing that this case really nicely demonstrates is, even with the sinus approach, how important it is to have a wide range of instruments. You need a full set of frontal sinus instruments with different Hall seekers, different angles. You need angled endoscopes and drills. You've got to be comfortable using those. So, you know, we've seen a huge variety of instruments being used very effectively in this case so far. And without that available, it would have become very difficult. So I appreciate that people are joining in countries that they may not have such a wide range of kit available, and appreciate the extra challenges that brings.
Scott, yeah.
Yes, I think to do this level of surgery, you really need to have a good amount of kit with you, and because you never know what the situation will demand. And other thing we noticed is that when Paolo was drilling over the lamina to smoothen down those cell partitions, he was using actually the very high speed pulse. It was a 35K revolution. So the faster you are, that doesn't necessarily mean you're aggressive. Rather, you get a better control with the faster burst. Is that fair?
Totally agree. You have to control the instrument. The problem is what you do with the instrument. It's not a problem usually the instrument, it's how we use it.
Yeah, very true.
So now I'm reducing the middle turbinate again. Biscotto.
So the Prof manual is ready in Valencia. So can we get Puya and Luis to join in, please? Thank you.
Ancora un pochettino. Biscotto ancora. Aspirami.
So now you're taking that bone of the middle turbinate to expose the meningeal seal again?
Yeah, here I'm trying to first make hemostasis and then to expose the olfactory cleft, looking for the meningeal seal. Yeah, go. So, please. Okay, thank you. Go. So now I'm with 0 degree, but I think I will move to a 45 now, because I need to better check the olfactory. So, and now you can see with this bleeding, I don't see exactly where is the attached. So I don't know if I have some more space here or not. So I put inside a little bit. Go. And then I want to check the olfactory. Go. Left. From the anterior part to the posterior, looking if there is still some bone. Here I have some bone, so I can reduce a little bit more. Biscotto. So I move to 45 degrees, it's better. 45. So we use, as you see, 0 degree and 45. I know that there are guys and colleagues that use 30 degrees, just a question of to being trained. So we prefer to shift from 0 towards the 45. We usually don't use too much procedures. So now thank you. So frontal here, the olfactory cleft starts from here. Let's see. Want to better check. You see? See, probably as times it happens, the CSF, you see, goes. There is an is a better analyze. It's still on the cleft here, but it would be better with the fluorescein. You can better understand what I mean. But now, if I will coagulate it here, I will expose the meningocele of the left side. So bipolar. So here, let's see. Ooh. Here the herniation. Yeah. No problem. That's better, sorry. Let's right. Seems to seem medial here. So I have drill here and reduce this part of the middle. So 0 degree, I will use a straight, then I will move towards a 45 degree. So we open this to check if there is something in here, the superior turbinates. To the same level olfactory cleft, the insertion of the middle turbinate. So drill, Medtronic, Trapano. Okay. So here we need to check if inside this cell there is the meningocele or not. It's very important. If not, it will continue growing and we will have a failure. Okay, so planum there. Okay, here. Okay, hyperostotic. Go. Okay. Now, luckily here does not seem to be a meningocele inside. Whoosh there. Very important, these things I'm doing to check the cleft and to expose the defect. Okay, bipolar again, bipolar. Go. Because herniating, you know that all the who's looking for us sometimes when the brain, frequently when the brain comes out with a meningocele, makes an hyperostotic bone bipolar all around, and this makes you feel that your herniation is quite low. Instead, you have to reduce the hyperostosis and follow the herniation till the exact point of origin of the meningo. So that's why I'm, drilling the bone, looking for the correct site of herniation. Okay, and we will move towards. So let's remove some mucosa here. Go. 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 You see, here the roof is pushed a little bit down. So there is a very thin bone at the level here of the posterior ethmoid, and we saw in the MR and TC before. So here, go. This is set. It's extended also at the level of the ethmoidal roof here. Posteriorly.
I think the more ill-defined margins of these olfactory cleft meningeal encapsulations make them so much more difficult to manage because it's easy to miss part of the meningocele. So, as you've done, really thorough exploration and is really important. It's easy just to see the main part and put a flap on it.
What makes us think that here there is something to be verified? It's this hyperostotic bone all around. Yeah. Okay, then drill again.
And the angle and the orientation of the defect can be another challenge as well. Getting that very well delineated and covered with the flap. Now I'd be very interested to see how you deal with that anterior end of the defect, because sometimes getting the flap very securely lying there can be difficult as well.
Okay, bipolar again.
Sorry, Paolo, you go.
Go.
I was going to say, in some ways, being bilateral and having to make that fenestration almost makes it easier because you've got margins on both sides that you can sort of identify and use to secure an underlay and then get your graft on the top. Would you use a bilateral approach had it been purely unilateral, or would you just put an overlay on it?
Oh, if it would be a single meningocele bilateral, you mean? Sorry?
If it had just been a unilateral meningeal encapsulated, how would your approach have
only
differed?
overlay. Yeah. Only overlay. Yeah. This and the hypertension intracranial. If not only overlay. In our experience, Apri, more you can close in more than 95% this kind of defect with the overlay in this area. So it's not always necessary to perform an ADAD flap. In this case, we choose the Haddad because of the reason that we discussed before. So, because you see, this is all soft and disruptive bone at the level of the olfactory cleft. Here. Okay, now let's remove the mucosa again. All the same concept. Vailina curva. Let's remove the mucosa of the ethmoidal roof again. I will give the endoscope, as we can say, to Mario Turri that will approach the sphenoid, so you can see also two surgeons, the same school. So we'll do. Yeah. Anterior ethmoidal artery, this one. Supraorbital recess. Here. Let's remove the mucosa. Viene a lavarti.
And Ashok mentioned it on the other side, but the anterior ethmoid is typically about a centimetre behind the frontal ostium. So people are always worried about it when they start operating, but it's further back from the frontal ostium, as you can see.
It can be variant, the distance between. So the anterior ethmoidal artery is the scariest things for who starts this kind of surgery.
Yeah.
Absolutely, but probably for somebody like you, Paolo, anterior ethmoid is a great friend. In a way, you can use it as a landmark to find your frontal and for often more extended procedures.
But anyway, I think the key point for the young surgeon is this one. When you are cutting the cells, mi dà una quattro tagliente, cutting the cells on the roof, never use vial. So, let's see, if I have a cutting instrument, I go at the level of anterior ethmoidal. If I cut it, it bleeds. And you coagulate in some way with this kind of bipolar. You see, as it happened to me before. You see, zoom. The problem, if you use, give me a vial. If you use at the level of the skull base, the vial, let's see. If I'm working with this kind of instrument, now I saw the artery, so I remove the mucosa, but if I go here and strip just to remove the cell, the thing is that you catch the artery, you bring it with you, and it enters inside the orbit. So, one key point from the youngest, who is the beginning of the surgery, never use the vial, the vial at the level of the roof of the ethmoid. Always use cutting instrument, as I showed you before. Okay, this is something, a message that you have to know. So if you are working there and you are cutting and removing the cell, use cutting instrument, tack. It bleeds, but you can control. Okay, it's simple message, clear, but it can avoid you some problems with the orbit. Okay. Do you agree?
Sorry, I was on mute. Yes, completely.
Yes.
Okay. Okay. Some mucosa here. Yeah, no. Yes. Okay. This is a sort of onodi. This is carotid, probably. So we can just put a little bit posterior. Here it finished the olfactory cleft. There is still some insertion over there. So biscotto. Okay, drill. Drill. I will smooth the field, removing the spar, the bony at this level, and then we will move towards Stenberg canal. Okay, go, please. And also with the drill, one trick is not to drill near to the orbit. If I want to drill the ethmoidal artery, I can do it, but medially. Go. Okay. Okay. Funghetto again. Okay. Now, what we can do, it's large a little bit the frontal, the side's quite good. Okay. And then, you see, but it's almost done. You will have to do the fenestration. So, now the flap, later on, the flap is, you see the Haddad on the right side. I have to bring also here on the olfactory cleft. So, here it's started what we were starting. Here, we have to make a hole here on the septum that goes from the posterior part of the olfactory cleft here till here the posterior wall of the frontal sinus. It will be very easy. The brider I can start doing, and then we will move towards the Stenberg, but we will make a superior fenestration. Like, you know, if it would be a flip flap towards the contralateral side, you can have this, you know, window above. So, in the upper part, you see, you open and make a superior fenestration. If there will be bone, you will drill it, but in such a way you can then bring the Haddad on this side toward this upper fenestration, but we will do later on, just to let you know what we are planning to do. Now I leave my microphone to Mario Turri for the Stenberg canal. See you later, guys. Thank you very much.
Oh, thank you, Paolo. Yeah. So it's almost another major case, isn't it? Closing the sphenoid defect. So we're getting to see these two procedures in one patient at one single setting. That's a great opportunity. And Mario, welcome and thank you for joining us. So Mario Turri-Zanoni, he is associate professor in Lake Como Hospital, again, University of Insubria in Italy. He has worked with Prof. Paolo Castelnuovo. He has also done his fellowship at MD Anderson in 2013 and done a PhD in life sciences and biotechnology, and now joined as associate professor. And is again a great teacher, goes around on the various courses. Just recently we're together in a Nottingham frontal sinus course. So good to see you back again, Mario. So over to you.
Hi.
So what is your plan today?
So just a little, I'm going to open the window at the level of a factory groove, right and the left side from one nostril, okay? And then we will go on later on for the reconstruction. Another thing I would like to do is to control the CSF leak on the groove here. I think that probably is there, more or less in this area, giving bipolar. And so once we have controlled this leak, okay, this is the small hole of the dura where the leak come out. And then CSF. Okay. Try to irrigate. Right side, left side. But there is one that okay. Okay.
Maria, can I say that your sound output is a bit not very consistent?
Very soft this area.
Okay. Yeah, that's better now.
With the bipolar, usually can help it. Approach. Noid.
Mario, your sound is, we're losing your sound in between. So can I get the technicians to sort of fix it out, please?
Can you hear? Ragazzi, non va l'audio. Can you hear me now?
Yes, that's better. Thank you.
Time to manage the defect at the level of a sphenoid. And there is a big debate in the literature about the nomenclature of such a kind of defect, because sometimes someone calls this defect lateral recess of a sphenoid defect, others call this defect we can say that the defect can be called stem.
We're losing your sound again, Mario.
No, non va l'audio. Non va l'audio.
Can you hear me now?
Yes, that's good.
Okay.
Thank you.
So you can say that the defect is a defect of a standard canal. The defect stays medially to the course of the second branch of the trigeminal nerve. Conversely, when the bony defect stays laterally to the V2, to the second branch of the trigeminal nerve, we can say that the defect is the defect of the lateral recess of the sphenoid. And so there is a big debate about this in literature. And in this specific case, we can say that probably this is a true stellar canal defect, because the defect stay exactly just a little medial to the course of the second branch of the trigeminal nerve. Now in the drill, we have to open our window. We have to enlarge the corridor at this point, at this level. And we have to harvest the so-called transpterygoid approach. It means that we have to drill out the upper part of the pterygoid, the so-called roots of the pterygoids. Dal biscotto, the cutting instrument. And we have to expose the basis sphenoid in order to get laterally.
So Maria, what factors help you to decide whether you're trying just the transsphenoid approach, wide sphenoidotomy, or transpterygoid? Are there any indication in the defect beforehand that help you?
We need to perform the transpterygoid when the defect stays very laterally. Basically laterally to the V2 or also very close to V2. In this case it's quite strange from anatomical viewpoint because V2 is very, very lateral. And so when V2 is so lateral, it's mandatory to perform transpterygoid approach to manage it and to approach it. What I would like to expose the basis sphenoid. Okay, I'm removing this bone. In order to see laterally. So give me circular punch in the corrector.
So would you now go and find the sphenopalatine electively?
Yeah. I enlarge my window. Like this, but I need to drill out more this bone. Presa. There is a septation here. This is a sort of septation, and you can go down at this level. This is the root of the pterygoids, and we have to drill out this root of the pterygoids. This is the area where the septal branch of the stenopalatine artery run, usually. And so I'm going to expose the bone, because I would like to drill out only the bone. This is the area also where stenopalatine artery run. Okay, suction here. I drill out just a little here, and then we have to remove all this bone, because we have to go down with our approach. Okay. 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 Now with the drill, we have to go down at the level of the anterior wall of the sphenoid. I have dissected down the mucosa from the bone so that now I can drill out only the bone. This is the root of the pterygoid. Okay. Okay. And more or less we have to go in this direction, okay?
Yes.
This is the course of V2. Semibipolare, bipolar. Okay. Finger. I have almost reached the floor. Good. This is the floor of the sphenoid. Auriculaire. Then with the Carrison Ranger, I open also superiorly. Because we have to identify the course of the tool. Carrison. I enlarge my window at this level. This is the mucosa. But of course we have to remove this mucosa because here we perform a skull base reconstruction, and so we have to remove all the mucosa from the bone. Allora vai piccolo per curva, more flexibile.
So Mario, would you routinely warn these patients about any possible numbness over the cheek or any dry eyes?
Yeah. We have discussed with this topic with the patient because of course now the patient, she's not complaining this, but when working very close to the second branch of the trigeminal nerve, it's possible to have numbness. Usually it's a temporary numbness because of inflammation related to the surgical procedure, and then these symptoms recover with time. But sometimes, not only transient symptoms, but the patient might have also some persistent symptoms. And so it's important to discuss this in the pre-op. Okay, this is the septation. Couple. Needs to be CSF. Spira.
I like your plan of exposing both of the defects fully before you make any final decisions on repair. You don't want to use your flap on the anterior defect and then find that your defect in the sphenoid is bigger than you expected.
Yeah, because sometimes might happen something different, then that suggests us to change strategy. And so we prefer to expose all the defects and then decide if our strategy can be confirmed or not. Okay. This is bone. There is something more here. Funghetto retto, circular punch, straight. Okay.
So can I check, Claire, what are your approaches to this? Similar or any variation that would you use?
I think I'd do something very similar. I would probably identify the SPA sort of more actively at the beginning to divide it, just for my own peace of mind. But same outcome.
And I think that helps to a degree as well to guide you into the IMAX if you really need to go very wide, secure everything. So.
Okay. I think now that we can drill out just a little more here at the level of the base, because the problem stay here.
The septation is going to make your access a bit challenging, isn't it?
Yeah. I have to drill out this septation, I think, because it becomes difficult to perform skull base reconstruction with this septation. Ah, bene, mi fai l'aspiratore, sono... non ce la fai con due robe. Drill.
And it's another challenge in this case, Claire, because often that septation is where you rest your pedicle of the flap.
Yeah.
So that's a good sort of support to lay your flap along the olfactory cleft, get it anteriorly. But on this occasion, because of this bilateral defect, you just have to balance that out a bit. There's a trade-off between the two.
That's the problem. Having both of the defects compromises some of your choices. For example, you couldn't raise a Haddad flap on this side because obviously you've compromised blood supply. So there are many things about this case that make it unusually difficult.
Yeah.
I commend the team at Lake Como for choosing this case. It's very easy to go for something a lot more simple.
Absolutely.
Also here, this area should be cleaned, should be drilled out.
And again, it underlines the importance, Claire, of the high levels, high volume centers, isn't it? I mean, for a complex cases like this, if you want to have good outcomes,
Bipolar.
It's important to have a high volume centralized centers who have expertise and all the technology available to do this.
Yeah, we've seen how well the sort of the four-handed technique works, how seamless it is when surgeons change between instruments. You know, all of that experience has made what is a very difficult case actually look relatively straightforward. But in most people's hands, it certainly wouldn't be.
A me biscotto.
Mario, with the lateral defects, how important is it to define the margins to be able to sort of reduce the meningocele? Is it exactly the same as on the anterior skull base?
Yeah, first we prefer to expose all the defects and then decide.
And when there's a greater sort of lateral extension and the defects that are lateral to V2, you can continue that transpterygoid approach as laterally sort of as you need, displacing the contents.
Yeah, I agree. So since the defect is quite lateral, we have to go lateral with the approach and we have to drill out all this bone. And so passing through the transmaxillary window, we have to drill out this part and get access to this lateral and inferior cell. Stay there. Drill. Okay, suction please. I enlarge the windows also just a little anterior in order to increase the view. Suction in the lateral area, okay. Suction again. No, devo andare basso, stai giù tu. Okay. And we can also explore the area with the 45-degree then, but now we need to expose the defect. We have to remove also this mucosa, of course. Drill. I try to drill out, staying inside to the cell and going outside from the cell with the drill. Suction. And I try to reduce also this septation, because this bony septation, it's quite challenging and reduce a lot of the space to work. Okay. Give me a small Blacksley, curved. la vailina singola curva. I have to remove all this mucosa because, of course, for the reconstruction we need to have exposed bone and not mucosa. Okay. There is a bleeding when you remove such a kind of mucosa. And now we have to enlarge this window drill. Suction. Okay. This septation should be just a little reduced. Ok.
Tagliano ancora un po'. Passetto lì.
O sulla carotida.
No, questa parte bassa. Utilizzo un po' sulla carotida. Io sulla carotida, ma qua basso.
Ok. Okay. So I have to reduce this septation because this bony septation inside the sphenoid makes the procedure harder and also may reduce space for skull base reconstruction. Suction please, also underside. Okay. So we have gained space medially with this septum. And now we have to go laterally. Laterally and inferiorly. Because we have to gain space to work at this level.
Do you look for the Vidian canal or the Vidian nerve? It almost looks as if you might be able to see the canal in the floor of the lateral extension.
Yeah. Yeah. Here at the level of the basis sphenoid, probably we will encounter Vidian canal. And probably it's not, we don't know if it is possible to preserve the Vidian nerve, because of course we have to go laterally. For sure we try to preserve the second branch of the trigeminal nerve, which is very close to the defect, but can be preserved. And about Vidian nerve we will see. Dammi una velina poco curva.
L'index di mucosa dell'ascellare.
Sì. Sì. I just a little lateralize this mucosa and I try to drill out this bone so that we can see in view, in just a little in front, our defect. So I think that I have to open this part, bipolar. I cauterize just a little the content of the pterygopalatine fossa, and then the content of the pterygopalatine fossa should be lateralized. Okay, then I push laterally. I push laterally this. Give me drill. Wash me. Aspira nello sfenoide. Aspira lo sbarrino faringe. So I'm going to expose the pterygopalatine fossa content, and so then I can push laterally, displace laterally the pterygopalatine fossa content. Okay. In order to expose this lateral part, give me cotton. I try to push laterally this area and also to identify the vidian which run at the level of the basis sphenoid. Ok, bipolar. Devo utilizzare il contenuto. Ah, vabbè. Ok. Ok. Okay. And now there is a pterygoid here. And I have to drill out this bone. Give me bipolar once again. Right? No, doesn't work. No, go. Ok. Drill. From inside to outside. Aspirazione. Aspiro bene.
Non c'è sorpresa, non riesco a scendere.
Ok.
Mario, what are your landmarks for V2?
V2 run at the level of the roof of the lateral recess of the sphenoid. Then I drill just a little more here. And then with the 45 degree we explore V2. Basically V2, you can follow V2 also because at the level of the infraorbital foramen, it runs at the level of the roof of the maxillary sinus, and it runs at this level. Because when you want to understand the height, the position of the V2, you can see the maxillary sinus, and remember that it runs more or less at this level.
That's a really helpful tip. So that wide antrostomy is really helpful in that regard as well.
Yeah. So because with the very wide antrostomy, we can get control. And so, more or less, the height is this one. We are looking for Vidian at this level, and this is the pterygopalatine fossa area, and V2 more or less stay there.
Yeah. So again, those fixed landmarks, really helpful, and you don't need the navigation.
Yeah. Yeah, but CSF leak here is coming from the olfactory. Now I'm looking for defects in this area. Give me cotonoids. Cotonino. Another one. Another one. Okay. So we put some vasoconstrictor soaked cotonoid here. And now 45-degree scope, we explore all the area because we are going to looking for the area of the defect. You know, in this specific case, we cannot use fluorescein, intrathecal injection of fluorescein, because of this allergy of a patient. And so we cannot be guided by the fluorescein. But we can try to understand. Ok, toglili. So, maxillary sinus, and this is the projection of the infraorbital nerve, so that we can understand the height of the infraorbital nerve. Okay. And with the 45-degree scope, probably here can be cleaned more. Dammi la vial singola curva. So V2.
Questa è doppia curva. E niente.
Okay. And so we can explore this area. We have a 45-degree scope turned laterally.
Mario, that's very nicely seen, the V2. Isn't it clear?
Yeah. V2,
yeah, that's really helpful.
Really helpful to understand the height. And this was the area we see on the CT scan. Probably this is the crest of the Didion here, at the level of the floor. At the level of the floor of the sphenoid. And I remember that the defect was just immediately close to the D2.
So when you palpate, is it still sort of, there's a bony covering on the lateral wall?
Yeah. I'm palpating with the suction, but I feel bone everywhere.
Yeah.
No, here no. Okay, no.
You can almost see the edges now that you've done.
This is the only part where I don't see the bone.
Yeah.
Yeah.
Nice. That's suddenly become really clear.
Everywhere, I feel bone everywhere, unless this part.
Yeah, we can see that pulsating there.
Yeah, it's important to palpate to understand where it's hard and where it's not hard. This is the median. This is the median nerve, okay? So usually, when there is a very high pneumatized lateral recess of a sphenoid, usually such a kind of defect stay laterally to the course of V2, and then can be called lateral recess of the sphenoid defect. But sometimes when the lateral recess of the sphenoid is very small, like in this case, low pneumatized, the defect can stay medially to V2, and so we can say that is a standard canal. So this is the area that we see on the CT scan without bone. Without bone. If I expose just a little low, I have to sacrifice Vidian. I drill out this bone here for sure. But I would like to preserve, I would like to preserve Vidian, if it's possible.
Does it make much difference to the patient? What's the morbidity of sacrificing the Vidian?
Yeah, exactly. Okay, so I think that we have to drill out all this bone. I show you. I have to drill out all this bone that stay in front of the defect in order to increase the view of the defect. And then we will see. But there is no CSF, to be honest. This is V2. This is V2 that runs like this, you can say, from here, the foramen, and then V2 is visible once again here posteriorly. Down there is the Vidian, V2, and this is the bony defect. So, we have to open the view to the defect by drilling out this bone. Drill. Stava Marco. Lavami. Non starmi davanti.
Non vedo dove sto.
Cerca di star mediano tu.
Devi farmi toccare.
Entro dentro mediano. So we have to coordinate our work with the second surgeon so that the suction stay medial and my drill stay lateral. Very particular case, because also the defect in the sphenoid is in a very uncommon location. Very close to the second branch of the trigeminal nerve.
And me and Claire both appreciate you for choosing this case, to be honest.
Bipolar.
It's really, really very educational.
Yeah. Bipolar. Dai. Okay. Bipolar. Okay. Once again. Okay.
It's probably fair to say that it has got all the elements of a blockbuster, isn't it, Claire?
Yeah, I mean, I'm very pleased for the team in Italy that they have two surgeons to hand over, because both cases are very difficult. Put together back to back, that would be very challenging. But your assistant is doing an absolutely fabulous job all the way through.
Yeah, I agree completely. So, almost get the target. We have to drill out just a little more of this bone. Here. This is the Vidian. Mi dai quello poco curvo da montare sul debrider?
Now that you can see the defect and its size, will you keep with the plan of using the Haddad flap on the olfactory cleft defect and putting a small underlay in this defect?
Yeah.
So you'll use the premucosal graft from your middle turbinate that you've harvested?
Yeah, we have the two middle turbinates, so we can take advantages of two grafts. Now we can decide how to use it.
Aspetta più piccola.
Okay, so we can palpate.
Have you changed the burr from the very angled burr that you had initially?
Yeah, now I have 45 degree scope. And now... No, voglio il drill, quello che fresa, la pallina, il drill cut, però non quello molto curvo, ma quello poco curvo. No, c'è anche la pallina meno curva di così. Ce ne sono poche? C'è. Quello con una curvatura meno potente di questa.
Come per fare col ticket per osservare il loro cesso?
So, hard bone, but here soft. This is the area of a bony defect, where we have seen also the pulsatile lesion. Here is hard bone. Lava.
Un po' girato di qua.
So the bone stay here. Devo prendere la fascia. Digli di iniziare a prendere la fascia.
C'è la gasket.
Ma cosa uso per la gasket?
C'è un grassolino.
Ma guardi che?
Il turbinato medio? Per gli osti? Ma se si fa di elastico secondo me, non c'è un
Okay, so there is bony absorption, but to be honest there is no leak CSF. Dammi anche il...
Mario, if you'd had the benefit of fluorescein and you'd seen from the outset that this wasn't leaking, would you still repair it because of the benign intracranial hypertension and the risk of a later leak?
Yeah, with the fluorescein it's more easy to understand the multiple sites of a defect, but luckily in this case we cannot use it, but yeah. Dammi il fungatoretto.
And sometimes you also see these intermittent leaks, isn't it, Claire? That
Yeah.
they close over sometimes, but
But I think even
Probably,
knowing there's a defect there and she's got benign intracranial hypertension, even though it's not leaking, you would still choose to reinforce that area.
Yeah, with such risk factor of intracranial hypertension, it's mandatory to resurface all the areas. We have also this drill that can be used. Is a very small and curved drill, but the problem is that there is a no diamond bar, but there is aggressive bar, so we have to stay very, very gentle. But it's just a little more curved than the standard drill, and staying very gently I can just a little. Mi riducete l'acqua? Anche due. I can make smooth the area here. Ok. Mi sa che devo iniziare a prendere la fascia lata.
Mettiamo un cotonino, vediamo se...
So you've got somebody harvesting fascia while you operate?
Yeah. I asked to other guys to start harvesting fascia lata from the right side of the patient because we need fascia lata here, and our strategy is to perform the gasket seal and cover everything with the free graft of turbinate.
Are you planning to use any fat, Mario?
Yeah. So give me once again the ball probe. See? And the cotonoid. This is the defect. This is the defect. Now I insert a cotonoid in order... No, un pezzetto, sì. In order to detach the epidural gap, I mean the space between dura and bone all around.
And the gasket seal is an overlay of fascia lata, but then held in place with a little bit of cartilage or bone rather than an underlay of cartilage.
Yeah. Usually put a small piece of fascia. Fascia should be at least 30% in size more than the defect. And then we put fragment inside. Hai l'aspiratore di Frank? Hai l'aspiratore di Frank? Metti sull'aspiratore di Frank, Marco.
No, c'è verso il basso.
I try to insert.
Una metà di questo.
Dov'è che è il seeker? I try to detach.
Another small tip here, that in the UK, we tend to use patties, the cotonoids, with the cocaine and adrenaline. So important to make sure that when the dura is exposed, not to use those patties. So your staff nurse should be aware of it.
Yeah.
It's very easy to happen.
Yeah,
that in the heat of the
absolutely.
surgery they can do.
Yeah,
Very,
once
very
the dura,
dilute.
yeah, once the dura is exposed, we do not use vasoconstrictors, but only saline.
Saline, exactly.
Only saline. So. Okay. I try to insert. Okay. I'm inserting the cotonoid in order to dissect the epidural gap. And then when we will have fascia,
That's a really nice tip. That works very well.
yeah. With the cotonoid, I dissect the dura from the bone, and also I try to understand exactly the borders of the bony defect. Okay. So the bony defects start from here.
Ashok, do you use fasciolata or do you use any of the sort of dural replacement grafts?
Probably.
Usually.
Yes, Mario.
Usually we use fasciolata, yeah.
On occasions, we do use a dural replacement, like Duragen, or like that. But of course, fasciolata is also one of the options.
Yeah, no, not so frequently we use Duragen or other dural substitutes.
Thank you.
So then here there is bone. So the bony defect is this one. And arrive until there, the bony defect. So I think that can be enough to put a fascia and a fragment of cartilage. Huh?
So there can be a variety of options of the. Sorry, Mario, you go first.
And then the mucoperiosteum.
Okay.
We can just a little enlarge here. We can better open here. Dammi bipolare.
I think you can have a different type of material options, but I think the basic principles are having a good, robust, multi-layer reconstruction, which is important. And again, going back to the basics, managing that root cause of it, benign interventional hypertension.
This is Vidian.
I think that I have to cut Vidian because it's not possible to.
You need to get to that inferior border, don't you?
Yeah. I have to cut Vidian and cauterize and increase the control of the inferior border. Okay.
So just in case we've got anyone joining sort of late, we've got the team from Lake Como dealing with a very challenging patient with benign intracranial hypertension and two separate areas of bony defect on the anterior, one on the anterior skull base bilaterally in the olfactory cleft, and another one which is a true Sternberg canal defect medial to V2 in the left sphenoid.
Right.
So that's obviously determined the choice of the graft, having to compromise the potential blood supply to a left-sided flap. So a right-sided Haddad flap has been partially prepared, and the anterior skull base has been exposed completely on both sides, removing all of the mucosa and defining the defect with a small ventilation to join the two. Mario is now working on the sphenoid defect and has exposed the lateral wall with a transpterygoid approach, but is now just coming down to really get to the inferior border so that can be closed as well. And meanwhile, someone else is harvesting fascia lata, so it shows how many people of the team have been involved and the complexity of the case.
I drill just a little more here. Cosa che sanguina sempre.
Non metti altri no, che puoi aiutarti.
Mm-hmm. Okay. Now we can put some cottonoids and I prepare the graft. Dammi i cotoni col vasocostrittore, quelli normali.
È una garza bagnata pulita.
Ancora un altro cotonino.
Ci servono i turbinati tagliati prima.
Dammi 2 turbinati.
I pezzi che ti abbiamo dato. Il costol e 2 Aston.
Ok. Now I prepare the turbinates. Mi fai luce tu? 0 degree scope. Avevi preso una
So Claire, do you tend to use any bone or cartilage for this reconstruction?
Avevi già preso dei pezzi cartilagine, no?
Probably wouldn't in the lateral sphenoid defect. I would probably try and get a little bit of an underlay and just an overlay of mucosal graft in that area. I tend to use cartilage if it's a bigger defect, and I want to sort of get a little bit more support. What about you?
Yes, probably I would agree with you. It's very similar. Try not to use it in the lateral sphenoid defects and all that. And yes, anteriorly, if the defect allows itself, then it can work as a good support, but as an intermediate support.
Yeah. And you mentioned fat. Do you use fat in the sphenoid?
Yes, we do sometimes with the lateral smaller defect, because often we find that the meningoencephalocele can appear bigger, but when you really get to the defects can be quite smaller and pinpoint. And laterally, getting that fat engaging, and it can be a bit of a challenge. So yes, the fat plug for those small defects almost work, but again, as one of the layers, you have to support it multi reconstruction. Yeah. even something like this, one can think of right-sided nasoseptal flap. It was just an isolated defect on its own. But here in this case, as we know, there's another challenge. We have to keep that right nasoseptal flap in reserve for your anterior skull base defect.
I really like the middle turbinate as a source of a free graft, but it's surprisingly difficult to elevate the mucosa. You can see that bone's really sort of invaginated in it. It's quite fiddly. So the cottles is perfect for that. And again, it's something that you just have to take your time on, particularly as you come round the bottom edge.
That puts a good demand on all your rhinology skills.
Yeah.
And especially the other side. If you leave it one side up, you leave it on the other side, that is, again, becomes very difficult. Very nicely done by Mario.
So we are elevating the graft from the middle turbinate. It's just a little attached, as usual. Okay, this is the bone inside.
You're ending up with a really nice sized piece of mucosa.
Yeah, seems to be enough to resurface the area.
To the team in Lake Como and everyone joining, I must send my apologies, but I'm afraid I'm going to have to dial out now. Congratulations to the team in Italy and especially to Ashok. It's been a fantastic morning so far. And I will watch the recorded video to see how the case ends, but I'm sure you'll get an excellent result. So I'm going to leave you in Ashok's very capable hands and the team in Lake Como. And thank you very much for allowing me to take part this morning. Thank you.
Thank you, Claire. It was an absolute privilege to have you on board with the GR-ESS and really enjoying your engaging discussion, the interaction with the faculty and your expertise in the area. It was really good. And Claire is catching up for international flight late afternoon today, so she will have to excuse herself. But thank you, despite all that busy schedule, taking the time out for us and being with us.
My pleasure. Thanks a lot, Ashok. Bye-bye.
Thank you. See you. Bye.
Thank you.
Dammi una pinzina. Thank you, thank you. Bye-bye. Paolo, tu avevi preso anche dei pezzi di cartilagine?
So today is the first day of our spring GRN live endoscopic sinus surgery. So we have a total 3 days event. It also involves one night. So today we are having a live surgery simultaneously performed at the very moment. As you can see on the screen, it is a Lake Como Hospital in Italy. Professor Paolo Battaglia, who has performed the surgery on the right side. He exposed the defect and created the flap. And now Mario is working on the lateral sphenoid defect on the left side. While in Valencia, Spain, Professor Manuel Bernal Spreckelsen and Irene, they are performing a complex SAMTRAS triad case. That's also a very interesting case. Those who are missing that case because you're logged in here, there will be an opportunity to see that recording once the case is over, so it will be available for you.
Fatemi luce qua, non è un granché bello questo turbino. Fammi luce con la scialittica. So, ce l'avete la fascia? So, now we can go. Paolo, tu puoi lavare un attimo che metti col turbinato che sia un po'... Aspetta, stai qua.
Flavia? Acqua?
L'avevano tolto il cotonino? Ah sì, anche quello. Ridaglieli tutti. C'è anche quello piccolo, eh. Sì, prendi.
Un pezzetto piccolo, non serve tanto.
So we're getting back on the endoscopic view. We are on the left nostril. We're looking at the left maxillary antrum, left sphenoid. Mario has delineated the defect.
Yeah.
And you can see the defect nicely with the intact bone around it. He has very skillfully separated the mucoperiosteum from the mucosal, from the middle turbinate on the right-hand side. Another team member has already harvested the graft, which is from the thigh. This is the fascia.
Vai. Ok. Fascia is almost ready, and so now we need to harvest a small fragment of cartilage.
Quando è sottile l'osso, no?
Vabbè.
Guardiamo un po' il pezzo dentro più solito per mettere poi il pezzo di cartilagine.
Però lì non lo bruciamo un pochettino.
Dammi ancora Vipo. Vai. So I want to control the bleeding here. Vai. Vai. Ok. So we can insert another cotonoid, very small, molto piccolo. Dici?
Mario,
Yeah?
any tips at this stage? Or any comments from Prof. Paolo Castelnuovo?
Yeah? Sì. Dammi il cotto. Cotton?
Da mascellare, ce l'ha Paolo.
C'era il dottor Battaglia dopo.
Un'altra roba allora.
Strong closure, reconstruction skull base, because this is related to the basically to the intracranial hypertension. So for this kind of lesion on the lateral wall of sphenoid, we can do some more easy reconstruction, but not in this case. Also for the olfactory. In the olfactory, we are used to use only underlay only overlay with a mucoperiosteum of middle but in such a case related to the intracranial hypertension, a pedicle flap like a Haddad flap is more common. So the more important surgery they are doing now is related to the intracranial hypertension.
So I have inserted once again another cotonoid in the defect, you can see. And in this way, first I detach the dura from the bone. Second, I better understand the true dimension of the defect, okay? That is small, luckily. And so I can understand how much big harvest the cartilage. So it's enough very small piece of cartilage, okay, to be inserted here in this area. So I go to the septum and I go to bring to harvest a very small part of small piece of cartilage. Give me cotton. I cut 1 centimeter cartilage here, from here. Can be enough. Can be also helpful for the septoplasty. Okay. Give me Fomon forceps. Dai. Uh-huh. Blacksley vial. So I have harvested this small piece of cartilage. Okay. This is the cartilage. Okay. One of the most important things of cartilage is that it's very pliable and versatile, and it's possible to compress cartilage because bone is much more hard. Dammi la forbicina con le punte. But cartilage is soft and so can be compressed without problems, and this makes cartilage very good material for this reason. I remove the angle of cartilage. Or especially the part of the cartilage that is very, very thick. Because if it is small and pliable, it can be inserted much better. Dice?
Vediamo Paolo.
Huh? Vial, and I try if it is good as a dimension, or we have to cut just a little more. This is my fragment of cartilage. Now we go directly at the level of the defect. Suction. Togli cotone. Togli cotone. I go to check the dimension of my cartilage, and it's big. You see the pulsatile area here?
Yes.
But the cartilage is pulsatile. The cotonoid that stays inside between dura and bone have helped in dissection of epidural gap, but my cartilage is too big. I have to reduce it more. Forbici, forceps. Che dici, toglie la parte spessa qua?
Ma lei non mi sa.
Che dici così?
Anche meno. Guarda questo angolino un po' puntuto qua.
I'm cutting the cartilage.
Una pinzetta, se no.
Poi entra, poi
No,
entra.
infatti va bene così.
Ok, so it's time to put fascia lata.
Per vedere come la prepariamo.
Okay, this is the fascia that we have prepared on the scrub nurse table.
Ok. Yeah.
È troppo piccola la fascia?
No, prova, dopo te ne faccio più grande.
Ok, with the black sleeve vial. Sì. I try to put the fascia.
Mi dai posizione? No.
This is the fragment of fascia lata.
That's your first layer, correct?
Cotton. Fammi spirare. Cotton. So, fascia seems to be good. I slide the fascia posteriorly.
Dammi la pagina.
To cover the defect. Okay. This is folded here. I don't like it folded here. But now I'm going to unfold the fascia. Aspetta, ce l'ho fatta. Ok. Now it's unfolded and is exactly at the level of the defect. Suction in the sphenoid, Vale. Suction, please. Okay. Okay. Fascia stay exactly there. And now, with just a little bit of lucky, we try to insert in the defect. Vailina? Ancora grossa.
Grossissima.
It's big. I have to reduce just a little more.
La metà devi fare.
Così it's big. Forbici. Sembra ancora grossa. Taglio questa parte che è quella spessa. Ma sì, dovrebbe andare bene così.
Facciamo un filo.
Hai scongelato la colla? 8. Ok. Cotto. Ce l'abbiamo? Posizionatore? No, quello dritto praticamente. To do this, we use such a kind of instrument, which has very small teeth on the tip and help us for this maneuver.
That's a very nice handy instrument.
Stai là dentro anche tu?
Ci provo. Non ci arriva. Laterale. Mi mette all'orizzontale. È rotolato.
Lo spingi anche tu?
Devo arrivare di
Hello, there is a security label on the screen. Can IT guys remove that, please? Is it from the studio end or is it from the center?
Spingi davanti. No. Sì. Ma porca vacca.
C'è perché laterale.
We can try to put a stitch.
Facciamo un altro tentativo. Velina?
La mia velina. Intanto che prendo il punto provo ancora una volta, ma... Ah, tutta dentro, dici?
Mi dai la forbicina, Flavia?
Ci dai per fare...
Dammi il cotto.
È un po' poco, è un po' troppo questa, è un po' poco.
Troppo tanta?
Troppo piccola.
No, no. Anterior lever is not so much.
I think one of the key aspects of the surgery today that we are witnessing is, Paolo, Maria, both of you have exercised such a great deal of patience in meticulously controlling the bleeding, denuding the mucosa, creating the recipient bed, creating the flap, and also we can see now engaging that fascia and the cartilage into the defect. You really need a great patience and just keep at it. So thank you.
Thank you, Ashok. We are trying to do our best for our patient.
And it's a great learning for the juniors who are watching. So, what is the name of the instrument that you're using? That supporting the graft?
We call positioning instruments for dura.
Okay.
And it's quite good because there is some teeth that keep the fascia, the dura. Suction.
Yes, otherwise the ordinary ball probes or even the straight probes, they tend to bring the fascia out and destabilize the graft, so which is really very handy instrument.
Okay. I can also insert a cotonoid, ma dopo mi viene fuori tutto. Ah, aspetta, spiego quella goccia qua davanti. I need to insert the posterior part. Okay. So superior, inferior is inside. Now we try non so, ma perché ha dei bordi del cazzo. I try to insert cartilage probably now.
Prova dietro, non ci dà.
Là, aspirami, lo so.
La purezza? Too much?
Because in some areas the bony borders are very, very thin. I try to put cartilage. Ancora grossa.
Ho fatto piccolino, piccolino.
Aspetta.
Si buca, si buca. Buca.
Oh. Unluckily this cartilage is we need another cartilage because it's broken. Vial is broken. Un altro pezzo? Unluckily. È un pezzo più duro?
Aspetta che arrivo. Deve entrare.
What do you think about? È entrata? Is inside.
Ho davanti. Qui non c'è più osso, lì è il periosso della fossa.
I think it's okay. Huh? Sì. Is inside. So it's quite okay here. The cartilage This second cartilage that Paolo Battaglia gave me, it's much more harder, much more bony, and so stay inside, because otherwise the other one was very soft and broken in the middle. But this one goes inside, very good. And so now we cover the area. What do you think about Paolo? Huh? Mucoperiosteum?
Non c'è l'altro mucoperiosteo.
Ma che cazzo ce ne frega? Give me.
That looks a very robust first layer
Staccato,
now.
no? Tieni qua, tanto è piccolo. Fammi luce. No, ma va bene anche questo. Fammi luce, Marco. Io tolgo solo la parte grossa. Ma sì, poi dopo si accartoccia tutto, non ci accorge. Ascoltami.
Posizionatori.
Now we put the mucoperiosteum. Of course, it's quite important to understand and to remember that we have to put the mucoperiosteum on the right position, because you know that we have to put periosteum against the bone and mucosa at the level of the nasal cavity. Okay? Of course, this is not a flap, so it's not vascularized, but it helps in the remucosalization of the cavity.
So that's almost like your third layer now.
Yeah? Give me cotonoids, only with saline. We can also cover just a little the pterygopalatine fossa here. Un cotonino. Aspira sul cotone, Marco. No, più grosso. Più grosso? Sì. No, dammelo ancora, ma più grosso. Un altro più grosso di cotone. Dammelo un terzo del cotone normale. Va bene, dai.
Tagliarlo?
Sì, taglialo così. Perfetto. Aspirami sul cotone. Aspira il cotone. Aspira mediale. Ok, esci pure. Ok, metto già la colla o aspettiamo dopo?
Come dici tu? Lascialo no.
Togli?
Questa è la volta.
Oh no. Ah, è attaccato.
Fai così, dai, aspetta. Siamo lì. Adesso lo togliamo.
No, è not possible. Lascia
No,
stare.
aspetta, tienilo che io...
Sì. Toglielo sotto.
La metto una carenza, no? La chiudo e basta.
Aspetta un poco. È la colla? Mi dai una palla di Tabotan grosso?
Dove vuoi metterla? Sabato, dove vuoi metterla? Commenta.
Okay. Now we put a piece of Tabotamp, Spongostam. Here only to keep in place our reconstruction.
Do you use any glue here?
Yeah.
Maria?
At the end we will improve once again. This is only to keep in place the free graft of a mucosa at this level. Okay? Then we will improve once again with the glue and other pieces. Paolo, we want to go. Now we have to manage the anterior cranial fossa defect here.
Yes,
And there is some liquor.
So, can you open my microphone? So, Hakos, still alive and here. I'm Paolo
So we
Battaglia.
have, while Paolo is preparing the skull base defect, we have Prof. Manuel Bernal has joined back to us. He has completed his very difficult case of Samtra-striate nasal polyposis.
Yeah.
So he's with us. Welcome back, Manuel, on the studio.
Thank you very much for inviting us to be part of this great event.
Thank you for joining. It was a privilege, and thank you to all your team for wonderful efforts to make this possible. All your theater team, the anesthetics, the technical team, then Irene. So all have been just wonderful. And I hear on the second channel, the delegates have enjoyed the case. Both the cases were Samtra-striate, very difficult nasal polyposis. So Dinesh, can you get a Prof. Manual on the screen, please?
So now I will prepare my dad.
Okay.
And hoprala. So let's start with posteriorly, building up the pedicle, so I can coagulate this tail, this branches for bipolar, please, for the middle turbinate. So here again, bipolar, so I'm coagulating the septal, the turbinate branches of the sphenopalatine, avoiding to damage the sphenopalatine artery itself. So now, as I told you, I want to have a large DAD flap, so I build up.
Thank you, Paolo. Yeah. So while you're preparing the flap on the screen, we'll have a brief from Prof. Manuel about his cases today. So,
Perfect.
Yeah. So can we get Prof. on the screen, please? Dinesh?
My best wishes to Italy.
Yeah.
Yes. Hi, Bernal.
Hi, Manuel.
It's great to see you.
My pleasure. I mean, you could have chosen an easier case, but knowing
Yeah.
your skill.
Only one CSF, not three in the same time.
Great, yeah. Oh, but you are able to solve it, so no issue.
Yeah, no, but we learn from Castelnuovo, you know, when things are difficult, it's better. So now I will extend my Haddad flap here inferiorly, beaver. So just at the level of the inferior meatus. Hop. So.
Do you have any questions, Puya, for Paolo?
I think. Ciao Paolo, ciao Mario, ciao Prof. Good morning, everyone.
Ciao, ciao Puya.
How are you?
Put up, please, the turbinate. I have to work inside. Ok. Piccole forbicine, piccole, scissor. Tira su sto turbinato. It's quite difficult to elevate here the flap. Here just be inferiorly to the inferior turbinate in the inferior meatus, but we will try. Okay. Elevation. Wash. I don't know, Mario, why I have to do the bloody things and you know. Okay. Wash. Ok. Altro aspiratore.
Muscolatore?
Sì, forbicina retta. No, quella da naso. With a small scissor now I'll try to cut here laterally and horizontally under the meatus. No, non stai fermo là. Fermo là. So wash, please. Try not, here you see you have the Asner valve here, the tip of my scissor. So I stay down, stay inferiorly. Non funziona. Datemi delle forbicine che tagliano, per carità. Me le dia verso sinistra, basta che taglino. Ok. Cotton. So in such a way I can take 2 centimeters more, 1.5 in the for my Haddad, you see? I pull it up, pull it up here, then cut this small, okay, small scissor on the right. So, thank you. Okay. Okay. Tenga. Here again, cotton. Now I did the anterior incision, the lateral one, and now then we will check here posteriorly at the passage of the hard and the soft palate, but we will take care later on. Now we'll go up. So here I need to go very high. So, forbicina che taglia verso destra. Sì.
So we have Prof manual now on the screen. So welcome, Prof.
So now I need to go very high here. I don't need to preserve the olfaction, so I go very high. But here anteriorly, we are anterior to olfactory cleft anyway, so help me please, Marco, that is the guy that helped us for all the surgery. He's helping us. He's well trained in this advanced surgery, Marco Valentini. Thank you, Marco. Put it down a little bit.
Vailina?
Yeah, let's work for hands. Take, push it down a little bit. Scissor, piccole rette. Okay. So, here. Okay. With the scissor, we can control exactly our extension of the flap. So, okay. Cotton. Okay. The axilla of the middle turbinate here. Usually it's our landmark. So, scissor, small one. No, forbicina, scissor. Let's detach from above. Okay, put it down, please. Okay. Okay. Again, posti.
Devo riprenderlo.
Cotton. Okay. Still attached a little bit here. So cotton. Okay. Try not to make a hole with the contralateral periosteum. So I can push it back. Yeah. Just put it back a little bit to gain some space anteriorly. Aspira un po'. Okay. Thank you. Touch from the contralateral periosteum. The hole that we had at the beginning of the surgery. I have to be quite, pay attention here, not to detach better the mucoperiosteum of the right side from the left side here. Okay, good. Okay, so we are at the level of the base sphenoid here. Here we detach quite well from the contralateral side. Forbicina piccola. So this is the fenestration that we performed before. Okay. Ok, Cottle again. Aspirami dentro. Ok, biscotto. Biscotto. O forbicina, quello che vuoi. Forbicina, qua. Forbicina. Okay, so there is detached. Let's see Cottle. Let's see here. So now we can put the flap again up in order to make the posterior incision. So up again, okay, up, okay. Guardate se non aspira più quasi niente, se...
A mezzo chiudo l'aspiratore.
No, questo non. So there is this inferior turbinate here. Tiramelo su. Spingi un po'. Aspirazione. No. Okay. So, beaver. Beaver. So, tail of the middle turbinate, superior part of the choana. We have an incision here posteriorly, the posterior incision of the haddad here. Aspira. Fighting again with the blood. Okay. And here, inferiorly, at the level of the floor. So this is soft palate, this is hard palate. I can palpate, so this is my posterior limit at the level of the floor of the nasal floor. And so I will extend my inferior incision laterally under the turbinate. Can you turn? Thank you. Okay. Okay. Fermo. Ok. Okay. Let's try Cottle. Vai. Spiro. It's quite difficult when we have to extend it posteriorly and laterally. Aspiratore, scollatore. Forbicina. Tira su così, bravo. Because we are working in narrow spaces. Work. Okay. Okay. Questo più piccolo. Aspira. Tieni così. Forbicina. Taglia un cazzo. Perché non taglia? Dammi quella che mangia a destra.
Vuoi Elina?
Ispiratore, scollatore piccolino. Allora, forbicina che tagli, dritta sarebbe.
So when developing the right nasoseptal flap, that partially it was elevated before the defect was delineated. Now it's zeroing on the pedicle, so freeing the pedicle so they get a good swing, because the flap has to reach to the anterior skull base, olfactory cleft area, as anteriorly as possible.
Forbicina.
Always very tedious with the bleeding and the different angles to find the pedicle, get through that.
Good. So let's put it up.
A shock. So we had missed some of this because we were in the breakout room. So can I just double check? We're using an extended nasoseptal flap for the defect in the cribriform. Is that correct? And then
yes, Louise, I think it's a good time to catch up. Yeah, correct. Yeah. So I think what we've done is there were two defects. There are actually two defects on the right side olfactory cleft, which was also extending into the central part, one of the defects, and there was a lateral sphenoidal defect.
Okay.
So for the lateral sphenoid, Mario has used transpterygoid approach. So it drilled down, exposed the defect nicely, defined the bony margins, and then they have used gasket seal with cartilage from the septum, then facial latter, and also the mucoperiostomas from the middle turbinate that he harvested as a third layer on the left-hand side. On the right side, Paolo has delineated the defect and has developed this nasoseptal flap. So he had partially lifted the flap before the defect was dealt with, and now it's completing lifting of the flap. As you can see, there's zeroing on the pedicle so that they get a good swing, good reach, and trying to line the defect now with the nasoseptal flap. So that's the plan for the right side. It's a vascularized flap reconstruction.
How quickly do you do these, Ashok, when you see them in the NHS as an outpatient?
Yeah, that's a good question. So it really depends on the waiting list. So the kind of elective patients, but you can't keep them hanging on too long as well. So I think depending on the demand of the waiting list, within a few months, they should be done. Yeah.
Yeah.
It's not most ideal. But,
it's
that's part of
difficult,
the
isn't
system. Yeah,
yes,
exactly.
I think we list them to ideally be done within 3 months, which is a sort of stage down from cancer. But often that stage down from cancer waits significantly longer than that.
Yeah, true. Yeah. So how are things at your end, Mario or Paolo? Do you want to take that question? So if the patient lands in your unit with this sort of CSF leak and the defects, what is kind of the waiting time for the operation? What is your prioritization?
What is it? Sorry.
Waiting time for the surgery.
Yeah.
Timing.
Yes, please. Yeah. How long do the patients end up waiting for the surgery?
Oh, it's 20 days.
Yeah. More or less 1 month, because we start with acetazolamide 1 month before, and so 1 month.
Tira su.
Okay, that's pretty good.
Is a patient with a CSF leak with high risk of meningitis, encephalitis, and so patient like this cannot wait so much.
What is your position on prophylactic antibiotics? Do you keep?
Yeah. We start yesterday with the third generation, the cephalosporin.
Okay. And would you continue that post-operatively?
Yeah, usually we continue 6-7 days after surgery.
Okay. And how long do the patients end up staying in the hospital?
So usually we remove nasal taking the second day after surgery, and we check the skull base reconstruction. After that, we invite the patient to stay in the bed with the head more or less at 35 degrees. After 3-4 days after surgery, we invite the patient to sit down, and more or less in 5 days after surgery, the patient wake up and start to walk. And if no problems are evident at the level of endoscopic examination of the skull base reconstruction, after 5-6 days after surgery, the patient will be discharged from hospital.
For Vicina?
We go very slow, progressively. So 2 days nasal taking, 3rd day sit down, 5 days walk, and if everything is good, 6 days home.
Okay.
I'm extending my superior septal window here, posteriorly.
Yes. What will be the post-op care, Mario?
About the post-operative care.
After the discharge.
Yeah. So basically, since the patient stay admitted in the hospital, we perform daily endoscopic evaluation to check the skull base reconstruction. But of course, when the patient will be discharged from hospital, this is not possible, and so
Fraser.
we discharge patient from hospital with very precise instruction. First, not to blow the nose. Second, not to do very strong exercise for at least 2-3 weeks after surgery. And usually we see the patient in the outpatient department for an endoscopic endomesal evaluation the week before the hospital discharge. So we discharge the patient from hospital, and after 8 days we will see in the hospital for outpatient consultation and endoscopic medication, because you know that sometimes it's important to perform nasal debridement. I mean, you have to remove some nasal crusting, to do suction of the secretions within the paranasal sinuses, and so to check the patency of the frontal sinuses, check the patency of the maxillary, of the sphenoid, and also, of course, check the skull base reconstruction. If everything goes good, 8 days after surgery, 8 days after dischargement, we see once again the patient 2 weeks after to control. Another important thing in patient like this, because
bipolar
intracranial hypertension, is that we have to follow the patient with some magnetic resonance during the life, in order to understand and rule out possible recurrences. Recurrences of CSF leak might appear at the level of a previous CSF leak, but also in different sites. That's why it's important to perform the first magnetic resonance 4 months after surgery, and then another one 6 months after surgery, and also invite the patient to go on with the diuretic therapy. One of the most important drawback of the diuretic therapy is the electrolytic problems. So it's important that the patient also will check blood test, blood exam, to check the balance of sodium and other electrolytic balance.
Thank you.
45 degree. Ulteriormente, sì.
So what is your post-op imaging schedule, Luis?
Usually, in the very immediate post-op, we perform CT scan the second day after surgery to rule out intracranial bleeding, and also to assess the degree of pneumocephalus, because sometimes it happens that the patient might have some very small air bubble in the anterior cranial fossa. And so such CT scan, early CT scan, it's important to understand the baseline. So during the hospital admission, if the patient will complain CSF leak recurrence or headache, we perform another CT scan, and we can compare the second CT scan with the first one in order to understand if problems are present. Conversely, if no problem will appear, we do not repeat another CT scan during the hospital admission.
Doppia curva.
Regarding the follow-up, for the follow-up we use magnetic resonance imaging, and the first magnetic resonance imaging will be performed 4 months after surgery, and if no problems will be present, no recurrences of CSF. We will perform another MR scan after 6 months.
Thank you, Maria.
I think one of the biggest difficulties we've had with these patients with idiopathic intracranial hypertension is them coming back within maybe the first week to 10 days post-operatively with severe headache. So we, at that point, developed a protocol with the neurosurgeons. So they would have a lumbar puncture with their pressures measured. And if they had high pressures, then they would go on for further assessment under the neurosurgeons and potentially have a drain to measure their intracranial pressures. So we try and avoid that as much as possible.
Yeah. To manage headache and intracranial hypertension, usually we administer 2 times per day diuretic therapy. And usually it is enough to decrease intracranial hypertension and to control also symptoms. But of course, not in all cases, not in 100% of cases. Usually we use lumbar tap, lumbar puncture, lumbar drainage only for selected cases where diuretic therapy is not enough. And so lumbar puncture, lumbar drainage, or even in very selected cases, ventriculoperitoneal shunt can be used for cases where diuretic therapy is not enough to manage and to control the intracranial pressure. But of course, we have to build up a very strict cooperation with our neurosurgical department, with our neurosurgeons, because such a kind of disease should be managed in a multidisciplinary way together with neurosurgeons. And so, for example, this case has been evaluated before surgery from our neurosurgeon, and we decide together the surgical plan. So, of course, this kind of the surgical procedure has been performed completely via endoscopic endonasal approach, and so has been performed by ENT surgeon. But the patient has been discussed preoperatively in a multidisciplinary way with our neurosurgeon. And our neurosurgeon is informed about this case, and so we will manage the patient together after surgery. This is important because if a lumbar tap, lumbar drainage, or other invasive procedure will be needed, we can cooperate with our neurosurgeon.
Okay, and are there any instances, any cases where the neurosurgeons stay involved in the surgery itself?
Yeah, should be involved in the management of a patient.
Posizionatore. Now, as you can see, we turn the ADAD covering both nasal fossa, but we have to drill here to get more space. So good. Mi mette quella fresa, quella... Ok.
Aspetta che non ce la più.
Ok, debrider anche dopo. No, No, non gli volevo fare una draft 3.
La parte di 8 del testo, la parte italiana di testo che arriva di 8 di...
Aspetta. The Bride? Sì. Poi I need a cutting la frontale.
Ah no, vuoi la frontale.
Bipolare. Ok. Go. 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 Ok. Da vai il 4, doppia curva. Problema al sangue. Aspira sotto da qualche parte. Lo taglio.
Preparavo 2 conetti di Silastic da mettere sulle frontali.
È una buona idea.
Prendiamo il Silastic, quello sottile,
vedo,
che facciamo i
pieno di
coni
sangue.
col punto, ti ricordi?
Che volevo lasciare centrale per un...
Ecco, la posizione di là non è coperta bene. È come se l'avessi piegato così.
Adesso curvo.
Tiratore curvo. Ce n'era uno anche qua, del retto, che lo attacco qua.
Quattro, doppia curva. Tira qua. Devo lasciarlo qua dividere.
So Louis, we also saw in the morning that because of the benign intracranial hypertension, it was quite challenging to control the bleeding by hypotensive anesthesia. But despite that, so very meticulously, Paolo has dealt with the sinus surgery side of it. So very retrograde ancynectomy, wide middle metal ultrasostomy, finding all the landmarks. Clear the ethmoids very nicely with following the principles by working from back to front and using the through-cutting instruments. So when especially it is very critical when you're dealing with the area, anteroethmoid area, that you're not using any grabbing instruments to pull the mucosa, because that can endanger the anteroethmoid artery. So he was very particular about it. And he found the frontal recesses on both the sides. Especially on the left side, the frontal recess was very tricky. So using the angled endoscopes, then using the nasolacrimal duct as a landmark, he widened it with the drill as well on the left-hand side. And the frontal, other challenge was a frontal beak. It was quite a thick beak with a narrow anterior-posterior diameter. So he managed to get a good, reasonable frontal ostium widening to maintain the long-term patency. And likewise on the right side, and all the anteroethmoid arteries were very well defined. Especially on the right side, there was an intermediate ethmoid. So there was an anteroethmoid, intermediate ethmoid, and the posterior ethmoid. So we saw all those three arteries. So it was a wonderful display of anatomy. And as you know, that you have to prepare the bed because the flap, the nasolacrimal flap, vascularis flap, it seeks the bone. And it removed all the mucosa very meticulously along the lamina. All the cell partitions were smoothed down with the drill. So all these little things that add to the success rate of the surgery. So if you're looking for a good long-term outcomes, you have to be careful about all these things.
And with regards to the ethmoid
so that was very well seen today.
Sorry,
yes.
I was just going to ask, were the ethmoid arteries cauterized as well once they were exposed, or were they left?
I think the arteries were within the skull, within the bone. So we didn't really have to drill it, cauterize, but there were some branches on the right side. There were some branches of the anteroethmoid, and one was particularly bleeding along the axilla. So he had cauterized those arteries. And one of the trick that he showed about is when you're dealing with the anteroethmoid area, anteroethmoid artery, you need to be dealing with it more medially. Otherwise, you can end up getting the anteroethmoid retracted into the orbit. So that was a good demonstration of the technique.
Okay. Now you see, I put the Haddad covering both olfactory cleft with this superior window on the septum. You see, the patient has still is all intact septum dividing the two nasal fossa. Here the pedicle that we could put here on the lateral wall, but here will not be stretched too much. And so the pedicle brings up the pedal of the flap here that covers the olfactory cleft here, the ethmoidal roof posteriorly. Here we are at the level of the sphenoid, where Mario performed yet the closure. This is the glue, the fibrin glue.
Più basso, poco più basso.
Oh, here, yeah.
Pensate.
Mario. Okay. It arrives here posteriorly, good. Then let's check to the contralateral side. So maxillary sinus again, sphenoid, and we will see better with 0 degree. All the flap that cover also the right olfactory cleft. Let's see.
Stavo cercando un modo per risparmiarla. Ma ne abbiamo ancora poi o no?
To check if there is a turning, ok.
Eseguire questo materiale perché il mio ex collega non era riuscito a trovare niente.
Devo ordinarla.
No, sì, però non ho neanche un conto.
Open.
Quindi mettiamo in contatto con la fidanzata del Marco Valentini.
Frontal sinus
perché
on the right side.
che poi credo che non sia neanche una cosa poi così costosa questa qua in verità.
Skull base.
Più utili, sono anche le più utili, le più semplici di solito.
Ok.
Niente, devo usare questa parte qui.
So 0 degree now, we'll check the front, the sphenoid.
And I think you need to be careful, don't you, afterwards, that you spend the time on the sinuses so that you don't end up, after doing a lengthy, difficult procedure with good skull base repairs, ending up with a mucus seal, for example, in one of the sinuses because it's not been exposed properly.
You're absolutely right. That's why Paolo took his own time. So removing every bit of mucosa that was possible to remove, all along the lamina, all along the skull base.
I could put the pedicle also here laterally, but no, I'm a little bit scared that he will not arrive here on the left side. So I don't want to stress too much the pedicle. I think it can cover better, can cover enough the skull. So I'll put some fibrin glue just to take in place the flap. Here, Mario reconstruction. Try not to ruin his good work. Seems the CSF not to be no more present. Okay. Covers also here posterior. Okay. So just to be sure, I coagulate again the sphenopalatine branches here. Not to have problem this night. Go. 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 Okay. Fibrin glue posteriorly.
And what packing material will we be using after this?
Oh, now we will put some spongostan.
Okay.
And then at the end we'll put the Merocell 2000 that are, in order to avoid there is lubrication or with the gloves, so we can cover if you don't have this kind of packing, you can use the gloves and to put around your packing. But we don't put anything that makes pressure against the flap. We only believe on tensive effect.
Okay.
So it will stay in place in such a way. Okay. Now I will put elastic paraseptal here. I will put this elastic to increase to make the healing of the septum faster. And then mettiamo gli stent. So we can now use 45 degree. Let's check. We prepared the two stents for the frontal, not to make it open, but just you know, to avoid a lot of medication and to support the flap in the anterior part. Okay, so stent. Let's check if it works here.
So there's a elastic stent, correct?
Yeah.
Okay, thank you.
Beh, sono troppo grossi. So. Sì, posizionatore? Sì.
Vai Lina? Stai lì che te la faccio scorrere, tu stai dentro quel coso qui. Io la faccio scorrere su. No. Cioè tu entri nel coso nel seno, io faccio tutto lo spingo su. Riesco ad arrivarci. E tu non riesci a entrare nello stent e con quello puoi entrare nel seno frontale. Mario, scusa, sei davanti?
Sembrano are quite too big, I think, the stents. No. I will take care about the frontal by medication. No, I don't like it's too big this elastic. So I prefer. No, I don't like. I prefer not to put the stent if it's too large. But no, it's okay. It's okay. I will not put the stent. I wanted to avoid to move too much the flap. The most important thing is the flap. So. I will take care personally. So 0 degree, elastic. A little bit of tabotamp.
So what's the next stage now? The PCBU and PACS, right?
No, I will take care about the frontal sinus because this elastic it's too large. I don't like.
So use a smaller stent, yeah.
Yeah, I will take care with the medication.
Okay.
Now I put some tabotamp here, Pongostan or Tabotamp as you want. Fibrin glue. Tabotamp.
Any comments from Prof. Castelnuovo?
Prof?
To put a silastic roll in the frontal, it's convenient only if the silastic has the right, thick. The one Paolo has now was too thick, so it's better not to make any damage to the flap. And Oxycell, like this, is good to promote the adhesion of the flap to the skull, but you have not to press on the pedicle of the flap, not to the patient. So we put some Oxycell around and fibrin glue to promote the adhesion, but to avoid the compression of the pedicle. And then finally he will put a paraseptal silastic, and this we leave for 3 weeks. So this promotes the revitalization of the contralateral septum and avoid the crust.
Thank you, Prof.
Okay. You see on the borders, as Castelnuovo told you just here, the window, here on the upper part of the septum. Here, no holes, luckily, and not too much. Okay, just a little bit more, but it's enough. And then silastic, just central here. Not pushing on the pedicle, as Professor Castelnuovo told you. Cosa? No? Ancora un pochettino? One more. Vial? Okay. Okay. On the sphenoid, one more. On the right. Perfect. The pedicle is free. It's ok. Sì.
Allina?
Sì. Qua l'ho messo. Sì. Perfect. Now silastic. We leave exposed the cartilago, so the silastic promote the healing. So we put here under, endoscopic control. So one stitch here. Yeah, also in the contralateral side. Better. Okay. Does not give any support, just to promote the healing of the septum. Hudson. Okay, one stitch here, just anterior to the cartilago here. Okay, Perfect. So 1, 2, 3. Poi Merocell. Here. Okay. Then we'll put this, lubricated faking. He takes the elastic and I put it under control, not to put at the level of the Duraplasti, but behind towards the Koana. Okay. This is perfect. Okay. And then one more. Okay, I go inside and I control the tip. Okay, just below towards the Koana. And I think it's done.
Thank you, Paolo. Mario, Paolo, that was absolutely wonderful. It's a very complex case, very nicely done with a great deal of patience and very meticulous techniques, safe techniques. So the trainees are watching this. It's a really good example of how to deal with these cases and how to deal with the sinus surgery and skull-based surgical techniques. So thank you, Prof. Paolo.
Thank you, Ashok.
For being there. And it was always wonderful to have your team. It's right from the first Lioness that we started, live surgical event in 2014 to now. And it has been a great support. And all our delegates have enjoyed the surgeries over the years and they will continue to do so. And I no doubt Paolo, Mario will take that further. Thank you to your anesthetist, the whole theatre team. Thank you to your technical team. They all have done a wonderful job. Very good visuals, very good audio. So thank you, everybody. Any comments from your side, from your team side?
Well, I think to thank you all for the invitation. It was a great honor for us to be with you. I think it was a very challenging case. And they have done a very good job with a lot of time, but this time was needed to be precise and meticulous because the skull-based reconstruction secret of the structures is to be really very meticulous. So thank you so much. Thank you to everybody for the collaboration, the technical staff, the anesthesiologists that are so important, the nurses and everybody. And I leave the hand to Paolo.
Yes, I want to thank you again for inviting us and all the staff here. That it's a big work with all of staff all around. It's not easy, but I want to say you hello from Como and see you soon.
Bye bye. Bye bye. Thank you.
Okay. Thank you. You deserve a big round of applause, whole team. So thank you again. Okay, Louise, any last comments?
Yeah, I think obviously I was in the breakout room, so I missed part of the surgery, but I think it just shows how meticulous you need to be. And, you know, for the trainees, it's from uncinectomy right up to skull-based surgery. You need to have a safe, meticulous technique if you want to be able to do these more complex cases. So I thought it was a fantastic demonstration of that.
Thank you. So thank you to all of you. And this is our first day concluded with the 2 surgeries from Spain and this fantastic surgery from Lake Como Hospital. Now we'll start again on Wednesday. We join Columbus, Ohio to Professor Rick Carra and Daniel Prevedelo for their skull-based case. And then further we'll join to Professor Richard Harvey in Sydney. So thank you to our technical team as well here. And we'll see you on Wednesday.
See you. Thank you.
Bye. Bye. See you. Bye. So, what a wonderful day it is. So,
Yeah, it
all
really
fascinating
fantastic.
surgeries and throughout. Yeah.
I think it shows, you know, if you skull-based surgery, I always think of it as made up of modules, and I think people always want to jump to the more complex cases because they find them interesting, you know, for the trainees. But actually, if you split the operation up, you can break it down into the different parts, you know, uncinectomy, middle meatal antrostomy, ethmoidectomy, and you're practicing all the time when you do these inflammatory cases for your skull-based surgeries. So I think that's really important as a concept for the trainees to understand.
Yeah, absolutely. And these are almost, you get the sinuses, non-disease sinuses. So you can do a very anatomical surgical dissection for these sinuses. So that's a good training example as well. So it's important that if you have skull-based departments attached, then so making sure you attend those theater sessions, not only the chronology sessions, but adds to your training potential. So thank you, and we will see you on Wednesday. This recording of these two channels from Spain and Italy will be available for you to watch afterwards. We know a lot of you joining from different time zones, so you will have this opportunity to watch this. It will be ongoing until Wednesday and even after. To stay updated, become a member of a GR-ESS Academy. So a lot of similar events and our various initiatives you'll be updated on. So thank you again, and see you on Wednesday, the 27th of March.